Yes, please.
Representative John Hunt, present.
I am here and I'm by myself.
Okay. Representative
Sorry.
John Petusik. Representative John Hunt, present.
Now I can hear you. You're repeating. Is that someone?
Sorry, that's me.
Okay. So Petusik said he might be late. So keep going.
I'll watch for him. Representative Jason Osborne. Keith Ammon, that's me here, and I'm by myself. Representative Max Abramson.
Here by myself.
Representative Bonnie Ham. Representative Ham.
I don't see her.
Representative Joseph DePalma.
Here and alone.
Representative Jeffrey Greason. Representative Greason.
I don't see him.
Representative Dawn Johnson.
Here and alone, but I do have 2 teenage daughters who will probably be running in and out behind me at some point because they're home without anything to do.
Okay.
But they're not in the room with me now. They're up in their rooms.
Representative Paul Terry.
Present alone.
Representative Christy Bartlett.
Only in my room.
Representative Richard Abel.
Representative Abel, I am at home. I'm alone in the room. My wife is elsewhere in the house.
Okay. Representative Chris Herbert.
I'm here, I'm alone, except my wife is in the house working from home.
Representative Connie Van Houten.
Present, and I'm alone.
Okay. Representative Tina Fargo.
I'm here. I'm alone in the room. My husband is in another part of the house.
All right. Representative Joyce Weston.
I'm here. I'm alone in my office. There is somebody else in the house.
Okay. Representative Jane Ballou.
I'm here. I'm home alone, but my daughter may be in and out later on.
Okay. Representative Anita Burrows.
I am here. I'm alone in the room. My husband's in the house, and there are way too many animals in the house as well.
All right. And last but not least, Representative Chris McAleer.
Representative Ammon, I amend my presence to note that my wife is also present in the house. Thank you.
Okay. Thank you. That's it.
Okay. I see Jeff Greason just joined us. So.
Yes, thank you, Mr. Chairman.
Okay. And
assume you're
noting him present.
Okay. All right. So I guess we'll open up the public hearing on HB 62. So Bill, I'm going to promote you to a panelist so we can see your smiling face. Okay. Now I see John Petusik has arrived. Morning,
Thank
Bill.
you, Mr. Chairman and members of the Commerce Committee. It's a pleasure to be with you today. It's refreshing compared to being with my committee. This morning, I am, for the record, I'm Representative William Marsh, representing 7 towns in Southern Carroll County. Relevant to House Bill 62, I also chair the New Hampshire Rare Disease Advisory Council. And I'm pleased to offer for your consideration today House Bill 62 relative to continued in-network access to certain healthcare providers. This bill began with a concern brought to the Rare Disease Advisory Council last spring. Briefly, since rare disease patients have diseases about which few doctors have any expertise or experience, they frequently choose their insurance products based on whether that product allows access to the particular doctor who may have expertise in their particular rare disease. When panels are narrowed, they may lose access to the doctor they believed they would have had access to when they purchased their insurance product. Consequently, they are left paying for a product which they believe provides little or no value to them. The language of this bill is based on Georgia Senate Bill 352, which passed the Georgia Senate last year. Simply, if an insurer includes a provider in its published directory, which a prospective insured used in selecting their health plan, then the insurer must maintain access to that provider until the renewal date. Exceptions are made if a provider loses their license or unilaterally terminates participation. In my mind, this is simply a truth in advertising issue. Insurers would never be subject to this provision if they did not publish directories which effectively promised prospective insureds access to particular providers. Tyler Brannon advised me that modification of RSA 420J7D would require an update to the contract provision in RSA 420J8. I did email you all amendment 0067H last week, and that would accomplish that revision as well. Thank you. And with that, I'm willing to take questions.
Okay, great. Thank you. Hey, Chris, when you sit up, maybe it's best to just turn your camera off before you do that. Okay. All right. Let's see. Are there any questions for Representative Marsh? Okay. Guess it's a pretty straightforward bill.
Thank you.
So next, so I guess we're all set. Thank you much. And you can certainly stay on and watch while we...
I'll stay for the next bill.
Oh, yeah, that's right. That's right. Okay, so next I have is Heidi Kroll. So Heidi, would you raise your hand and then I will upgrade you to a panelist. There you are. And you bump up and promote to panelist. And okay, you're on, Heidi.
Can you hear me? Okay, Mr. Chairman?
Everything's good.
Good. All right, great. Good morning, Mr. Chairman and members of the committee. It's good to see everybody and thank you for having me. My name is Heidi Kroll. I work at Gallagher, Callahan & Gartrell, and I'm here today representing AHIP, which is America's Health Insurance Plans. We are the National Trade Association for the health insurance carriers, and obviously have a number of members here in New Hampshire. AHIP respectfully opposes House Bill 62 for a number of reasons, and I know others will be testifying about this as well. The first thing I wanted to say, I think, is that the providers do quite a bit of work maintaining their provider directories. They're updated very regularly, and in addition, it's something that the department keeps a close eye on. I know that they can be provider directories can be included in market conduct exams, and there's improvements are required, and the carriers carry out those improvements. So we wanted to mention that as the 60-day provision, which was just mentioned by Representative Marsh, that is an important provision in there in law to protect consumers. To ensure that if their provider has left the network for whatever reason, that the consumer is able to continue using that provider for 60 days as if the provider had not left the network. So there are continuity of care provisions and protections in current law. The other thing we are concerned about with this bill is that it undermines the value of provider networks. So carriers, spend a lot of time developing their networks and carefully selecting providers based on providers' credentialing, quality of service, patient safety, those sorts of things to really ensure that the providers that they have included in their networks are of the utmost quality in terms of providing high quality and affordable services. The other concern that we have with the bill is that there would be no protection for the patient in terms of balanced billing. You may recall a couple years ago, we had House Bill 1809. That bill only applies to anesthesiology, radiology, emergency medicine, and pathology. So any of other providers who are out of network under this bill would still be free to balance bill the patient. So there's language in here about ensuring that, I think basically that the covered person is, kind of kept whole. And so I don't think that there's really any way that, we can have that sort of insurance. So that in a nutshell, those are the reasons that we are opposed to House Bill 62, and we would respectfully request that you find this bill to be inexpedient to legislate. And I'd be happy to try to answer any questions, or if I'm not able to, other speakers may be able to, or we can certainly take it back with the carriers and get back to you with answers.
Okay, we do have a question. Representative Burrows has a question.
Thank you for taking my question. Back to, I assume you were on when Representative Marsh was speaking, and how would you respond to his concern that a patient, for example, who has a rare disease, who signed on to a network, maybe specifically for the purpose of having access to a rare disease specialist, and then that person, they suddenly may be cut off from that? How does the insurance industry respond to that concern?
Sure, and there may be other carriers who can amplify on this, but I think generally speaking, first of all, there are network adequacy requirements that the carriers are required to meet or exceed. So, I think that there might not be that specific provider, the person's name still in the network, but there could be other providers who provide the same services. And obviously are meeting high quality standards as well. The other thing I will say is that there are provisions for care for patients to receive care by out of network providers. So if that patient really felt strongly about continuing to be a patient with that provider, they would have the ability to do so.
Thank you.
Representative Abramson has a question.
Thank you, Mr. Chair, and thank you for taking my question. The question I was trying to raise my hand for under William Marsh, but maybe you can answer. Is there an estimate on how much this would increase insurance premiums if the bill passed?
I don't have an estimate, but we certainly do believe that there could be upward pressure on premiums. And I would add that I believe that the insurance department will probably be testifying before you today. It's my understanding that requests can be made of the insurance department anytime there's kind of a new mandate type of bill that's being considered, that they have the ability upon request to do an analysis to try to understand the impacts. So that could be something that the insurance department could potentially take a look at.
Follow up?
For the question, may inquire.
Is there a way to amend this bill so that hypothetically, if you had a service provider and they're originally charging a certain cost for services, if they were to try to increase what they bill the insurance company at too great an increase in a year, that there would be some kind of outlet in place under the bill to allow the insurance carrier to essentially say no? In other words, if they increase their price by 17% 1 year without an explanation.
Well, I think I'm not a contracting expert by any stretch of the imagination, but at a high level, I believe that when the carriers enter into a contract with a provider or hospital or provider group, that is typically a 1-year contract. So during that contract period, I don't think that there would be any changes in terms of what the provider is billing or what the carrier is reimbursing. From year to year, those can be adjusted. And certainly if a carrier and a provider at the end of one contract, when negotiations are going on for the next contract, if the two parties are not able to come to an agreement, then there would be no contract and that provider would not be in the network.
Okay, any other questions for Attorney Kroll? Seeing none, thank you very much.
Thank you, Mr. Chairman.
And I guess I'll get you, Tyler Brennan, next. So there you are. Thank you. And are you on, Tyler? There you
Yes, and you can hear me and see me. Okay, I could see my little screen, but still had to click that pieces. So thank you. Tyler Brannon with the New Hampshire Insurance Department. I'm the Director of Health Economics, and we do not have a position on the bill, which, as most of you know, is traditional. I'm going to speak to both the bill and the amendment because I think the amendment potentially provides a little bit of clarification on some of the questions that came up. Clearly, there's the intention to protect the member so the member doesn't pay more than cost sharing when they go to a healthcare provider that is no longer in the network. But traditionally, if the healthcare provider is outside of the network, then they can charge the patient whatever they want because there is no agreement with the insurer to accept anything less. One of the ways we govern the relationship between a carrier and a healthcare provider is a section of the insurance statute called Provider Contract Standards. And within that existing provider contract standards, there is the continued access provision. So every contract with a healthcare provider needs to include language that says a member or patient can continue to access that healthcare provider under the arrangement that existed prior to the termination of the contract. But it's just for 60 days. So the amendment changes that provision and then links the original bill and says the member or the patient would have continued access for as long as they are under that contract, that subscriber certificate, in other words, their health insurance benefit agreement, which goes back to, I think, that the purpose of the bill, which is if you've selected a carrier based on the network, you've got kind of that ongoing access. We have experienced some confusion about how this would operationalize in the past. There is a requirement also for members to be notified about a provider that is leaving the network when some of these situations exist. There are questions sometimes about the patient liability. At least in theory, the patient would be protected. That being said, network development is constantly kind of an evolving thing. And when you think about the cycle that most employers or subscribers operate on, to the extent they're choosing their insurance, and many of them do it for a calendar year plan year, but not all of them. So if you're choosing in the fall, your insurance starts in January and goes through the calendar year. On the group side, it may not be synchronized with the calendar year. So to try and align kind of the network development, the contracting phase with that of the people buying their insurance would be a substantial challenge and probably not something that could be operationalized very easily. Even trying to make those adjustments deals with sort of cost sharing accumulators, a lot of other operational challenges. And even when you think about the budgets of hospitals, carriers, employers, they're all not going to be lined up. And that's what lends itself in part to this kind of disconnect and the challenge of synchronizing things in such a way that everybody chooses their network and the network doesn't change and you have that continued access. We will say that any change in legislatively that does give the providers more bargaining power, you are likely to see some inflationary pressure with claims. Simply, if they have more power, they can demand more. I was unaware that this kind of originated with some of the rare disease concerns. We tend to think of providers such as hospitals having the most bargaining power. It's very difficult to sell insurance without one of our major hospitals in the network. But that being said, the more a provider has kind of a lock on a particular service, they're more likely to act as a monopoly. So that's certainly a consideration. But at the same time, if you think about kind of continued access under the contract terms that were in place a year ago, that could be detrimental to a provider too. A provider that has accepted a fixed payment at a certain level, and now the underlying healthcare cost of treating somebody with a particular condition goes up. The provider wants to get more out of it. They can't live under the existing contract. And now the member or the patient has continued access at those lower reimbursement levels. So with a provider that's paid a percent of charges, they could just increase their charges. But I think it's going to potentially hit providers a little bit unequally. The insurance department is positioned to do what we call a mandate review. We refer to insurance mandates in the traditional way. In other words, it changes the scope of services that are covered. But the way our statute is actually written, it gives the department and the chair of a committee like this the flexibility to look at something that could be considered a mandate that actually is more than just the change in the scope of services. So the department would be able to do an analysis of the policy and the claims data to provide some estimate about how this might impact premiums. But it does take us, we tend to want to allow about 6 weeks to do the work, and it can cost about $25,000 to the department. That being said, we do have the contract in place, and we'd be happy to do the work for the committee if there's enough interest in doing that.
Great. We do have questions. Representative Herbert, you're up first. Chris, yeah. You can unmute.
Okay, the general, thank yous for being here. Is this I'm a little unsure about these people are specialists that are rare? I mean, I'm trying to figure out, do they charge more because of their expertise totally, or is it a situation where or are they just really busy because they're the only people that do this work, and they don't need any more business, and they raise their price if they can, or is it a situation? And if it is that kind of a situation, if it is a situation where it's just their specialty and they're not that busy, can insurance companies share these providers? I mean, so that they have have good business in the sense of being busy, as opposed to just somebody who's charging a premium because they have a specialty. I don't know if that made any sense, but I'm just trying to figure out a way to get around all these issues.
Yeah, so I think that, and I'll speak generally because I can't speak specifically to some of the issues that may have come up in the Rare Disease Council, but generally speaking, you are seeing fewer locations in healthcare, in the delivery system, that are performing very specialized services. And that's in part because medicine is becoming more complicated, but it's also becoming more expensive to set up basically a program or initiative at a particular setting. So you might see Dartmouth-Hitchcock with providing a number of services in Lebanon that aren't offered elsewhere in the state. The alternative is going to Boston. In the future, there may be fewer of those sites. Generally speaking, professionals, physicians are paid according to a kind of a fee schedule, and it's often based off of what Medicare would do. So it might be 200% of Medicare. Those physicians might be independent. They might be represented by a hospital. The hospital, on the other hand, could be paid at a substantially higher rate. So to the extent you start to see monopolies develop, they're probably going to take place both with consideration for the hospital and the actual physician or other providers that are involved. So I think to the extent there is recognition that there may be value or there is value in certain access to specialized services, in the future, we will see fewer sites with potentially stronger monopolies. When we developed the network adequacy rule, we developed requirements for a number of services you should get at the local level. Those things are primary care, those things are physical therapy, mental health type services. But for very specialized services, the best we could really do is say, look, those services need to be accessible within New England. We simply don't have enough providers that we could create a standard that would be local enough without creating a monopoly. And that provider saying, Carrie, you have to contract with me at whatever rates I demand. So that's maybe a more general answer than what you were looking for, but it is reflective of the trends we are seeing.
Thank you.
Right. Representative Abel.
Yes. Thank you, Mr. Brannan. It's good to see you again, and thank you for your testimony. I I'm trying to grasp the maximum time period that an insurance company, if this bill goes through, that an insurance company would have to continue to pay the specialist. And I think Ms. Kroll said that there's a 60-day already written in. There's a 60-day period. So that means if this all happened on the first day of coverage, there would be 10 months as a maximum that would continue. Is that correct?
Oh, I see. If I understand your question, you're talking about an additional 10 months. So, right. So
as a maximum,
you choose your insurance in November, December, your insurance starts in January, but as soon as you've chosen your insurance, then there's a dispute with the provider, they're out in network. Today, you should have continued access for January and February. Under the bill with the amendment, then you're in a situation where your insurance runs through December. So you presumably would have continued access to that provider throughout the calendar year. And so that would be a big change for sure.
May I follow up, please?
The question may inquire.
Yes. So that if we do not pass this bill, then the insured would have a maximum 10-month period to pay, which that person would have to pay extra under the current situation.
No, so not necessarily. So the idea with that continued access is that gives the carrier and the member a chance to find a provider rather than facing a cliff where they no longer have access, or as you were suggesting, have to pay the out-of-network arrangement. And that goes back to network adequacy requirements. There has to be access somewhere for those services that are covered under your plan benefit design, but it might mean moving from if an insurer didn't want to contract with Dartmouth-Hitchcock to a provider in Boston, something like that. That being said, we are talking about relatively rare scenarios that it would be at that level. I think it might be a more specific situation. But again, that continued access is to create a transition period.
Well said. Representative Bartlett.
Thank you. It's nice to see you, Mr. Brennan, again. Okay, so this isn't just necessarily going to apply to individually paid insurance contract. Is that correct?
Right. It's not specific to the individual or the group market. So, I mean, we've been using individuals because it's easiest to follow, but presumably you could have a group renewing in the middle of the calendar year and facing the same kind of situation where they've selected a carrier based on the network that's there, and but then there's a dispute in the contract, and they would have, presumably they should have continued access with the bill and the amendment to that provider. But right, yes.
Further question may inquire.
Thank you. So that if an employee really is not involved in negotiating an insurance contract and there's a 3-year term, this would extend more than just the 10 months we're talking about. It could extend for the life of the contract between the employer and the insurance company. Is that correct?
No, the way we would interpret the language, it's based on the plan year. So to the extent that an employer has signed up for their insurance, they may be intending to stay with the carrier for the next 3 years, but every year the rates are set just in place for a year, and that's when the plan year would take place.
Further question?
Thank you. But the employee is probably not involved in those negotiations. So they could really be stuck, couldn't they? If they.
So it's an interesting, you raise actually a larger question that I hope I don't be seen as digressing from, but individuals tend to be quite selective about their insurance products. That's why you might see more often narrow networks in the individual market, whereas in the group market, an employer tries to represent all their employees. So you tend fewer examples of narrow networks in the group market, and so nationally as much as locally. And in part because of the scenario you're describing, the individual employee doesn't have a lot of weight in the selection of the carrier and the product. So the employer tends to err on the side of having broader networks, richer benefit designs. And And of course, in the small group market, there are a lot of sort of market rules. And large group, it's seen as those employers being able to look after their employees and choose benefit designs with a fair amount of sophistication.
Thank you.
Okay. Before you go, Tyler, let me make sure I understand. In the bill, there's an exemptions or providers that it doesn't include. And notwithstanding, this is not, first of all, this doesn't look like it's just narrow to a specialist. This looks like all providers. Is that correct?
Yeah, that's an important point, and I should have made that. We're not talking about just rare diseases, and really, we're not even talking about providers just in New Hampshire. So you're literally talking about a contract change with what would be thousands of providers in a network. So it's I can't understate kind of the significance that this could have.
Okay, but on the other side, then when this exemption says, except if the provider becomes out of network due to suspension, expiration. Now, don't generally when an insurance company decides to say that they want to take a provider out of the network, don't they generally wait till their contract has expired?
There are two scenarios, and many of the contracts are what are considered evergreens. They will automatically renew, and those are with physicians more likely than hospitals. And hospital contracts can be multi-year contracts with provisions, but to the extent that there is an expiration date, that does force a negotiation more readily for sure.
Okay. Seems this bill would need a lot of work if we were going to try to pass it. Okay, is there any other questions for Mr. Brennan? Seeing none, we thank you very much for your testimony.
Okay.
Excuse me, Mr. Chairman, I just want to let you know Representative Ham has joined us by phone, and she's out in the attendee list. So she may raise her hand using the *9 feature on her phone.
Can I move her over?
I could not move her over. I was given the option of allowing her to speak or removing her from the meeting entirely, and I didn't want to do that.
Right.
But she can hear just fine from where she is, and if she knows how to raise her hand with the *9, she'll be able to participate.
Okay, so
Oh, you moved her.
I did. I just clicked her to allow her to talk. Yeah.
Oh, okay.
So I
And
guess.
could I just note that Representative McAleer is now present?
And also I did see he pops up too. So, okay, great. So that's it for people who want to testify. We have quite a list of people who signed up. I guess this is the feature or benefits of of having the electronic sign up. So let's see, we have a Carol Crawford, an elected official, this is a legislator, I assume, in support of the bill. Representative John McDonald is also in support of the bill. Senator Cindy Rosewall, she is in support of the bill. Jason Hart is opposed to the bill. And Lindsay Nadeau, she is opposed to the bill. Lacey Colligan is a member of the public and supports the bill. Paula Menahan from the Hospital Association in support of the bill. Holly Stevens from New Futures is in support of the bill. Statia Nichols is a member of the public and supports the bill. Joan Pajot was representing New Hampshire Association of Insurance Agents, supports the bill. Karen Privy, as a member of the public, supports the bill. Deborah Reagan Coffin, a member of the public, supports the bill. Eric Rathbun, also of the public, supports the bill. And finally, Sabrina Dunlap, who represents Anthem, is opposed to the bill.
And I see that Sabrina Dunlap, on that note, has raised her hand out in the attendees along
Okay,
with Peter Bragdon.
Okay, so Sabrina and Peter Bragdon. Okay. I think Peter did tell me ahead of time that he might have a problem, but I'll start with Sabrina first. And so Sabrina, I'm going to promote you to panelist so you can, I assume you want to testify. There she is.
Hello there. Thanks for bringing me over. Hi, everyone. I'm Sabrina Dunlap. I'm Director of Government Relations at Anthem. Thanks for having me. I won't repeat everything that Heidi said, but we do, Anthem does oppose this bill, and we agree largely with many of the concerns Heidi already raised. I do want to just emphasize that, as has been mentioned, the insurance regs do require access to out-of-network care if it can't be obtained in network. So I think that does get at the underlying concern with this bill. So happy to take any questions, but I also did submit written testimony on this. So thank you.
Right. I don't see any questions, so you're all set there. Okay. So Peter Bragdon, you also would like to testify? Peter, you there?
Oh, there we go. Can you hear me?
Yep.
Okay, good. Sorry. Thank you, Mr. Chairman. And I hadn't mentioned anything earlier, but I mistakenly was out shoveling snow and didn't realize I came in too late to make the 30-minute window. So I apologize for that. Thank you for your indulgence. Thank you, Mr. Chairman. For the record, Peter Bragdon, representing Harvard Pilgrim Healthcare, the state's only not-for-profit health insurer, a company founded by doctors providing coverage for over 100,000 of our friends and neighbors in the Granite State. And we are opposed to House Bill 62. It purports to protect consumers by allowing up to 1 year of what is, for all intents and purposes, in-network access, even though the provider has left the network. As had been stated, current law provides that covered members of our insurance plans can retain what is essentially in-network access to a provider for 60 days after the provider's contract with us ends, in order to allow appropriate transition of care. This would be a good place to point out that in some instances, we cover access those longer than 60 days in specific instances. And I think the whole purpose of this bill came about because of a specific instance that came about. And we oftentimes will consider specific circumstances. For example, the case of a terminal patient. We don't want to force that patient to transition to another provider. So we can work around it. The law does not say it has to be 60 days, but it certainly has a floor of 60 days. We're willing to work with people to take care of that. The proposal before you, because of the amendment, would replace the 60-day guaranteed consumer protection with a variable scheme that could be anywhere from 0 days to 365 days, given some of the timing issues. So in some cases, it gives consumers even less protection than they already have. In addition to less consumer protection, as Tyler mentioned, the bill will be very difficult to implement, keeping track of a data member enrolls and who was on the directory at the time. Perhaps this bill would be worthy of consideration if all of our health plans ran from January 1st to December 31st, and all of our provider contracts ran from January 1st to December 31st. But that's not the way it works. We have plans that start on just about every single month in the calendar, and we have provider contracts that also have a wide array of starting and ending dates. So we believe HB 62 would be unworkable in this environment. So we prefer the consumer protection that exists in current law. It's easy to understand, it's easy to implement, and rather than change the whole system for some isolated incidents, we urge you to find HB 62 an expedient legislation. Thank you very much.
Okay. Is there, Representative Aberson has a question if you're willing to take one.
I am.
Go ahead.
Thank you, Mr. Chair, and thank you for taking my question. What are some of the reasons that providers leave the network? Are they leaving on their own? Are they being forced out, or is it a mutual agreement?
I think in most cases, and I'm certainly no expert, but in most cases, the contracts just come to an end, and the negotiations about reimbursement rates for various things lead to one side or the other not being content.
All right.
Great. All right. Seeing no more questions, I will close the public hearing on House Bill 62. And we have a 2-minute break. I gotta go find my coffee.
Oh, before you run off, just wanted to let you know I got my vaccine yesterday, so I will be here all day.
All right. You got it early because of the snowstorm, huh?
That's right. State did a great job. Called us right at home on Sunday night.
Yeah, well, that is good.
But my arm hurts. It's a small price to pay.
Yes, that's for sure. But that's just your first one. There's the second one that's supposed to be more painful, but see what happens. Right?
I'll risk it.
All
Well,
right.
we haven't been able to sign up for the second one yet.
Yeah. All right. I got to go find my coffee. Just a second. What did I do with it?
Well, good morning all. I'm sorry I had to be late. I had 14 inches of fluff out in the driveway I had to play with. And it was heavy, but it was nice to see. So I'm back. Oh, by the way, Chris, I got the big notebook. Hang on, I'll show you. There it is. And everything is tabbed.
Yeah, but the problem is you're not sitting next to me anymore.
Well, we
That's
just have
why
to, we'll have to move the windows.
I guess so.
Well, hopefully someday in the near future, we'll be sitting back in the room. Now, good Lord willing, and hey, March 10th, that's my day. How you feeling, Christy? You got your shot, right? How you feeling?
Just fine. My arm's a little sore, but that's the only thing.
Yeah, I've heard from folks that we older people take it much better because we've had so much other stuff in our body already. And the young
It
folks,
could be.
the young folks get it hard because they haven't had all the stuff that we've had.
Well, we got most of the diseases. We didn't get all the vaccines, so I don't want this disease.
Yeah, I agree.
I remember measles, being very, very sick with measles. I was the first in the neighborhood to get it.
Yeah, back when I was like 4 or 5, I had diphtheria.
Oh,
Yeah, it was pretty heavy.
yeah.
But then, you know, they started coming out with all the shots. Then again, when I was 4 years old, it was way back in 1952.
Right. Well, I remember, I had mumps and German measles and
Oh, yeah.
all of
Yeah.
those, chicken pox.
We got-
Now,
We got
You
zillions
avoid
of
getting those.
antibodies floating around. All right, I'm gonna mute.
I just did it. I muted myself. Okay, so we'll open up the public hearing on 191 and hear from Representative Marsh. Good morning, Representative Marsh.
Hello again, everyone. For the record, I'm Representative William Marsh, representing 7 towns in Southern Carroll County. Relevant to this bill, I've been a trustee of Huggins Hospital since 2004, including 2 non-consecutive terms as corporate treasurer, and I'm retired from my solo private practice. I'm pleased today to offer for your consideration House Bill 191 relative to prior authorizations and patient transfers under the managed care group health insurance policies, which I filed at the request of the New Hampshire Hospital Association. First of all, this is not a bill to ban prior authorizations. It does 3 things. First, it requires 60 days notice for new prior authorization requirements. Doctors and hospitals need this. Tracking patients who have already been referred for a treatment or consultation is obviously burdensome, and it takes time to educate employed practitioners about new requirements so that they can comply. Second, the bill requires that prior authorizations remain valid for 6 months. Sometimes it takes that long to schedule a surgery or get an appointment to see a busy specialist. Third, last, and for me, this is the most important section of the bill. It limits the use of prior authorizations to delay the transfer of patients to step-down facilities. We all want patients to get the appropriate level of care. We all want to not spend too much money to provide that care. And understand that all of our hospitals have very narrow operating margins. In a fee-for-service hospital, extending the length of stay by 1 day can easily become financially burdensome. In critical access hospitals, this is even more of a problem, as one condition of participation in Medicare for critical access hospitals, maintaining an average length of stay of 96 hours or less. Hospitals do understand the need to have appropriate transport for such transfers, but delaying or preventing transfers to less expensive step-down facilities with prior authorizations is just not reasonable. COVID has hit the balance sheet of our hospitals particularly hard, so this last provision is particularly needed right now. Further, the recent surge of COVID strained our total hospital capacity. Delay in sending patients to step-down facilities exacerbates that problem. Promptly addressing this issue will better prepare New Hampshire to handle a potential surge from the new, more infectious strains of COVID that we hear are coming. I thank you all for consideration of my bill. I'll be glad to take questions. I can't stay for the entire hearing as I need to return to Health and Human Services to introduce another bill.
Any question? Yeah, Representative Abel has a question.
Yes, thank you. Thank you, Dr. and Representative Marsh. Does this apply to hospital services and to prescriptions, or is it just one or the other?
The short answer is yes. The third provision, the transfer provision, I don't think applies to prescriptions. That would strictly have to do with facilities.
Thank you.
Okay, any other questions? All right, seeing none, thank you very much.
Thank you.
I have quite a list here. So let's see, why don't we'll do another, so let's see if there's any other legislator who signed up. I don't see that right off the top. Okay, so then we're going up. Let's see. Well, here's is Matt Hode? Is he? Matt, are you on the attendee list? Matt, do I see Matt? Matt, are you there? He said he was going to testify, but
I see him on the list.
on the attendees list. Oh, there he is. Okay, there we go. Okay, I'm promoting you. And he's a former member of the committee. Good morning, Attorney Hood. How are you today? Hopefully he's almost there. There we go.
Thank you, Mr. Chairman. I am here. I hope that you can hear me.
Yes, I can.
Great. Thank you very much. And thank you for the opportunity to testify. My name is Matthew Hood. I'm the Vice President of Government Relations at Dartmouth Hitchcock. And I am here this morning to support House Bill 191, as we believe that it reduces barriers to necessary services. I'm going to highlight particular sections of the new 420J12 that would particularly alleviate patient as well as administrative burdens. Section 1, Representative Marsh spoke to this about scheduling procedures and having a 6-month window during which the prior authorization is valid. And I guess what I'd like to say is it's not just a schedule, but oftentimes patients need to reschedule appointments for many reasons, whether it's patient complications, provider illnesses or schedules, shortages of resources. COVID was mentioned, and as people know, that threw a wrench into scheduled procedures. Last spring, there was actually a bill that addressed that issue and pushed out the authorization date for procedures that may have been affected by that period of time. I would reiterate, this is not a blanket prohibition on prior authorizations, but it's a request to not have to start from ground zero. I don't think 6 months is particularly onerous. but I'm happy to engage in that conversation. The next piece that I'd like to speak to is when when patients are undergoing a procedure and the provider can see an otherwise previously unknown situation that requires additional treatment. Oftentimes, that secondary procedure that's done in the course of the primary procedure isn't covered because there wasn't a prior auth received for that. This is one that particularly strikes me as odd, since why would we ever want to make a patient go through two procedures in the same area? So I actually understand, Mr. Chairman and members of the committee, that insurers, the carriers have some concerns with experimental treatments in this context, but I'm fairly certain that the committee and others could draft language that would exclude experimental treatments as part of this provision. Finally, want to make sure it's final. I would reiterate the interfacility transport piece, since I think, again, that's a win-win for both providers and carriers. We have a patient who's been sitting at Dartmouth-Hitchcock since March of 2020. I'm not pretending that that is exclusively the result of failure to get a prior authorization for discharge. There's lots of complicating factors, but that's a bed for almost a year that can't be used. And the sooner people can, at a high acuity facility. So the sooner that people can move, the sooner that other additional patients who need treatment can get in. So with that, I'll conclude. Happy to answer any questions and appreciate your time.
I don't see any hands up, so I guess you get off easy today. Thank you.
I should say so. Thank you, Representative.
All right, so now we'll do one more support. Michael Padmore. So Michael, if you just raise your hand and jump to the top for me. There you are. Okay, promoted to a panelist. And Bonnie, you might want to mute. Oh, that's right. You're on the phone. Do you know the phone commands, Bonnie?
No, I guess not.
Let's see. I have them in my notes here somewhere. I think it's *9. Is that what it is?
*9 to raise your hand and *6 to mute and unmute.
*6. There we go.
Good morning. Can you hear me?
Yes. Good morning.
Great. Well, good morning. Thank you, Mr. Chairman and members of the committee. For the record, my name is Mike Padmore, and I'm the Director of Advocacy with the New Hampshire Medical Society, representing physicians across the state. The New Hampshire Medical Society strongly supports House Bill 191, which aims to reform the prior authorization process that private insurance companies have in place. With respect to time, I'll keep my remarks brief, as I've actually worked with a couple of our physicians and different practice managers who are involved with some of the different practices around the state who have been able to sign up to testify this morning, and I think can really speak directly to the impact of prior authorization better than I can. So I'll just close by saying that in addition to the New Hampshire Medical Society, 5 physician specialty organizations are also in strong support: the New Hampshire Academy of Family Physicians, American Academy of Pediatrics, the New Hampshire chapter, New Hampshire American College of Obstetricians and Gynecologists, the New Hampshire Academy of Emergency Physicians, and the New Hampshire Orthopedic Society. And then finally, I'll just refer you to my written testimony, which outlines actually just a number of different physician stories, nurse stories, just from a variety of providers and patients about how prior auth has impacted patient care. So with that, we urge you to vote ought to pass on House Bill 191, and I'm happy to answer any questions that you might have.
Great. Representative Van Houten has a question.
Thank you, and thank you for taking my testimony. It's good to see you back, Mr. Padmore. I have a question that is probably more basic than it needs to be, but I'd like to understand why prior authorization is necessary to move a patient to a lesser level of care. I just don't understand that. Wouldn't that just be automatic to move a patient to where he belongs, to a lesser expensive, conceivably, level of care?
Thank you for your question. And what I'll do, forgive me, I do think there may be some folks who are testifying after me who just can speak to that with much more experience than I can. So I'll defer to them and close my testimony. But again, happy to answer any additional questions.
Thank you. I appreciate that.
Okay. All right. So now we'll change the pace a little bit and we'll invite Heidi Kroll up, who will give us the other point of view. So Heidi, I think I took you out, so you need to raise your hand again so I can see you. Well, there you are. I see you now. You don't have to raise your hand. I'm promoting you to a panelist, Heidi. And are you there, Heidi? Maybe she stepped out. Oh, she did say she had another bill she was testifying on, so that must be where she is right now. Okay, so then who else? So I will have Sabrina Dunlap. And I know I had you here, and there you are. Okay, promote you back up. There you go. And
Hi again.
hi again.
Over. Okay. Hi, Sabrina Dunlap, Director of Government Relations at Anthem. I thank you for having me. I did submit written testimony from our medical director, Dick LaFleur, who could not be here today. So I did point out in our testimony two provisions in particular that I'd like to speak to. One is the procedure during another already approved procedure. So we generally do approve procedures that are medically necessary, but we do review them. And we think that's really important for patient safety and to make sure that the procedure that was performed during the other procedure was in fact medically appropriate. So I just want to flag that. And from what I can tell, we actually most of the time do approve these. So we don't really see that as a problem or a barrier to care at all. And then the second issue is the transfer issue. So we actually do not require prior auth for transfer. We're aligned with the providers. We would like to get patients to appropriate care, especially step-down care. So we actually don't require prior auth for the transfer. We do review the facility, however. And I think that's important to flag because we want to make sure patients actually end up in the correct place. And as far as I know, I've talked to our internal folks, we have very fast turnaround time on transfers. So again, we don't really see that as a problem. I mean, we're not seeing slow turnarounds, we're not seeing delays, and certainly prior auth is not a barrier to care or a barrier to being transferred. I would again emphasize the importance of patient safety here and the importance of reviewing the facility to make sure patients actually end up in the right place. So I think that's it for me. I do just want to emphasize that, we see prior auth as a really important care management tool. It's an important decision support tool. And I do think this bill undermines prior auth in a really detrimental way. And we do oppose it, obviously. So happy to take any questions and thank you very much for your time.
Any questions from the committee? Okay, seeing none, thank you very much. Okay, now we'll go, let's see, Paula Minahan from the New Hampshire Hospital Association. So Paula, if you raise your hand. Or she might be, there she is, okay. And good morning, Paula. And she might be in that other committee. Okay.
Oh, no.
There-
Can you hear me now?
Yes.
Representative?
Yes,
Sorry
I
about
can.
that. I didn't unmute properly. I have two Zoom's going, as you
Right.
I guessed. So I had to get on the right one. Sorry. Good morning, Mr. Chairman, members of the committee. My name is Paula Minahan, Senior Vice President, State Government Relations with the New Hampshire Hospital Association, representing all our hospitals. We are in strong support of HB 191, and we do thank Representative Marsh for agreeing to sponsor this bill. A Senate bill, Senate Bill 531, was introduced last year that attempted to address some of our the concerns of the provider community. And while some of those provisions of the Senate bill were passed last year and signed into law, 2 areas of concern remain, and they were outlined very well by Representative Marsh: the administrative complexities associated with the prior auths, as well as the transfer provision. We understand that the insurance carriers utilize prior auths, and again, we are not saying anything, we're not asking that that be removed. I just want to be very clear. All we are asking is that when a prior authorization is necessary, the floor goes from 3 months to 6 months. And I think Senator Hood did a very good job explaining, giving you some examples of when that occurs. So that is all that we're trying to do, is ensure that during, especially now, that we have so many issues with folks getting into a specialist, that the floor go from 3 months to 6 months to ease the burden for providers and patients. And I just want to mention, the carriers we have had discussions with the carriers, and they have suggested creating an electronic prior auth process that could address some of these issues, and we would agree. I think that is a great idea, and we welcome those discussions. However, the need to reduce administrative burden of prior auths needing to be reauthorized multiple times for the same service remains. I just wanted to mention the medical necessity. Again, Senator Hood outlined that well. It does happen. I heard the testimony of Ms. Dunlop, and I guess I would say that that is one carrier, and I don't know what the particular experience is with our hospitals, but certainly what I have heard is that this is a problem, and that obviously that's why we put this bill in. And then the last change was just going from a 30-day notice to a 60-day notice. A prior bill that we worked on actually had a much longer time frame, but we adjusted that to 60 days. The patient transfer is an issue that is very challenging. In fact, the Hospital Association and the Foundation for Healthy Communities actually creates yearly a barriers to discharge, we call it, or barriers to people receiving the right care. And we just produced a report that just is kind of hot off the presses, and I will share that with everyone after this hearing. But we do have a significant number of individuals that are unable to get to the lower level of care. We're not talking about transferring from an acute care hospital to Mass General. That is not, those emergencies are not the issue. We are trying to get patients, as again, Representative Marsh clarified, getting them to a lower level, such as rehab or a long-term care facility, and we just need to get them moved more quickly. There are carriers that require prior authorizations, again, hence why we put this in the bill. We are not looking to undermine any work that the carriers are doing, and to make sure that it is a legitimate transfer. That's why the language is written the way it is. And we're happy to continue to work with the carriers. We have met numerous times. I just wanted to be on the record, trying to come up with language or ask them for additional language, but we need something that really allows the providers, the hospitals in this case, to work to get to the right level of care, make sure they're using the transfer vendor that is appropriate and in network for the carrier. We're fine with all that. We just need them we need help getting them into the right level of care. That really is what we're trying to do. And like I said, I will share with everyone the barriers to discharge report that I think will be illuminating. We have the issue for a lot of carriers, including Medicare, but that this bill does not address that. We do believe that prior authorization, the changes to the prior authorization process are in the best interest of patients and will result in a more cost-effective care by eliminating inappropriate and unnecessary barriers. We support the bill, ask you to pass it, and I'm happy to answer any questions. Thank you so much.
Okay, any questions? Yeah, Representative Van Houten has a question.
Thank you. I just want to thank both Ms. Dunlap and Ms. Minahan for addressing my question and helping me understand better what the issues are. Thank you.
Okay. No more hands. And so I have just promoted Rebecca Zerbier.
That's very good. Are you able to hear me?
Yes, we are.
Thank you. Thank you
Oh,
for.
I'm sorry. Christy Bartlett just raised her hand. Christy, do you wanna-
I'm sorry, it was
Uh-oh.
for Ms. Minahan.
We're getting bombed here. Somebody's got something going on in the background.
There.
Okay, thank you.
I'm sorry, this is for Ms. Dunlap. I could not find the written testimony she said that was submitted earlier on behalf of Anthem.
Okay.
Does anybody else have that?
If I could, I sent it to the whole committee. I'm happy to send it to you directly. I did send it last night.
I'm sorry, I've missed it. somehow.
But it was written by our medical director, so I'm happy to.
Send it out again. That'd be great.
Okay.
Thank you.
Thank you.
Thank you.
Okay, go ahead.
Yes, thank you. Thank you for the opportunity to speak. I've met some of you before. I'm the director of breast imaging at Dartmouth Hitchcock Medical Center up here in Lebanon. And my testimony is brief, but best related by an example from a tragic story of how this requirement for pre-authorization can actually kill. And this is a true story from Pennsylvania, not from Dartmouth, thankfully, but a typical scenario is a woman came to a radiology facility. She had a breast lump and she had a prescription from her doctor for a diagnostic mammogram, which is where things usually start. The prescription did not include orders for unanticipated additional testing that would be required, but again, you can't guess what's going to happen. The physician could not be successfully contacted for this order for the additional imaging. And the patient left because otherwise she would have uncovered medical expenses in the thousands of dollars, and the medically appropriate testing to diagnose her lump as a breast cancer, which specifically would include ultrasound and ultrasound guided core biopsy, was not done. So the patient was told her mammogram was normal and she was sent home. She fell through the cracks. The provider thought radiology would pick it up and the radiologist thought the provider would pick it up. And she now has metastatic breast cancer and is actually in hospice. So the very act of having to stop and call someone like a referring provider or an insurance company when dealing with women afraid of having breast cancer, stressful, potentially life-threatening, is, in my opinion, as a caretaker, inhumane. It's inefficient regularly, and it's potentially dangerous. So neither the insurance company nor the referring provider have any training or knowledge of breast cancer or imaging findings or testing required. No one can predict or understand the specifics of the testing required, leaving unskilled decision makers in the way of timely diagnosis. So from my perspective, the only thing that pre-authorization requirement does is introduce inefficiency, suffering, and potential for actual harm and medical negligence. So I strongly encourage the passage of this bill to save everyone time, money, and distress, and possibly a life. Thank you.
Thank you. Any questions from the committee? Seeing none, thank you very much for your testimony.
Thank you.
So Heidi, are you back yet?
Good morning, Mr. Chairman. Yes, I am back.
Okay.
Sorry for that. Thank you very much for accommodating. I'm doing 2 Zooms. So again, good morning, Mr. Chairman and members of the committee. For the record, my name is Heidi Kroll. I work at Gallagher, Callahan, and Gartrell. I'm here today representing AHIP, which stands for America's Health Insurance Plans. We are the trade association for health insurance carriers. AHIP is opposed to House Bill 191 because it will restrict and undermine the use of prior authorization, which is a critical tool used to protect patient safety and promote evidence-based treatments and improved outcomes. We also oppose House Bill 191 because we believe it could lead to upward pressure on health insurance premiums at a time when New Hampshire residents and businesses cannot afford higher prices. I want to cover kind of 3 areas today. One is just a little bit about what prior authorization is and why it's important. Second, some background information on prior authorization in New Hampshire. And I did send you an email last night with a 2-page document. And then third, I wanted to just cover kind of alternative non-legislative solutions to House Bill 191. So first, a little bit about prior authorization and why it's important. Health plans use medical management tools such as prior authorization, step therapy, formularies, provider networks to ensure that patients receive access to safe, effective, and evidence-based care at an affordable cost. Prior authorization also helps to put certain patients on carriers' radar sooner rather than later, so that the carrier can actually help with patients' care coordination, namely getting the right care at the right setting at the right time. Prior authorization also targets certain prescription drugs and medical services that are prone to a wide variation in provider practices and the potential for either overuse, underuse, or misuse of services, which of course can have an impact on patient care and safety, as well as costs. When a prior authorization is required, and not every drug or service has a prior authorization, in fact, it's a small minority, but when it is required, the prior authorization protocols are developed and tailored very specifically to the particular drug or the medical service in question. So there is no one size fits all when it comes to prior authorization protocols. Prior authorization protocols are routinely reviewed and adjusted in response to changes in the safety, effectiveness, or value of an existing drug or medical procedure, as well as in response to new medical guidance or new drugs or procedures coming to market that may provide a more effective and cost-effective treatment. Federal programs such as Medicaid and Medicare recognize the value of prior authorization, as do providers, especially if providers that are in value-based reimbursement models. So when those providers are in those kind of contracts, value-based care contracts, where they have a stake in patient outcomes as well as cost and savings, the providers themselves actually also develop and use prior authorization protocols to help them deliver high quality medically necessary care in a cost-effective manner. So the point is that even providers recognize the value of prior authorization. Turning to the background and information on prior authorization in New Hampshire, first I wanted to let you know that to the best of AHIP's knowledge, other states do not have laws or provisions similar to House Bill 191. AHIP reviewed its database of laws related to prior authorization in other states and was unable to find laws similar to the ones proposed in House Bill 191. Secondly, in the handout that I emailed to you, you'll see a description of how carriers develop their utilization management programs, including prior authorization. And the bottom line is that utilization management policies are developed through a very rigorous process to ensure that they reflect the most current scientific data and also clinical knowledge. Third, it's important to know that in recent years, the legislature has made quite a number of significant amendments to New Hampshire's prior authorization laws, including 5 changes that were made last year pursuant to the passage of House Bill 1280 and House Bill 1639. The carriers came to the table and did a lot of negotiating with the Hospital Association, the Medical Society, and others, legislators as well. Those changes took effect between July 29th of 2020 and January 1st of this year. And we think it's important to give those changes some time and see what their impacts are before we start making more significant changes. Finally, it's important to understand that we do have consumer protection provisions in RSA 420E relative to licensure of medical utilization review entities. And these consumer protection provisions include time periods within which prior authorization must be determined, provisions for expedited review, and the right for both an internal and external review. And I will also mention that the carriers meet national standards as well around their prior authorization protocols. So finally, turning to non-legislative solutions. In our opinion, legislatively mandated restrictions like those proposed in House Bill 191 are far too broad and simply not appropriate. And we do believe that there are non-legislative solutions. We have spoken with the providers and offered that if the providers are running into problems with a particular prior authorization requirement that one or more carriers have, particular to a particular drug or a particular service, that we are, the medical directors and others at the carriers are all ears and more than willing to have discussions about amending particular prior authorization protocols. And in fact, this has happened historically where, one or more New Hampshire doctors will approach the medical director of a carrier and make them aware of some information, either late breaking news about a particular procedure or just maybe a problem that they're having. And the carriers are more than willing to work to try to see if it's appropriate to amend the protocols. But to the best of my knowledge, the providers have not of late taken the carriers up on this offer. The other thing that we did offer is to take specific examples of the problems that the providers are running into and try to crosswalk that with the use of the electronic prior authorization systems that the carriers have. It could help minimize or even avoid some of the problems. And so that's the other thing that I wanted to mention is that electronic prior authorization is a tool that can be used to kind of, ease the administrative burden of prior authorization that the providers have mentioned without losing the benefits of prior authorization. So that's something I wanted to mention, that we have those tools that can streamline the process and reduce the administrative burden for everyone involved. So in short, we strongly object to House Bill 191 because we feel it will undermine a critical tool used to protect patient safety and promote evidence-based treatments. And we are concerned it will drive up premiums for New Hampshire citizens and businesses. And with that, I'd be happy to answer any questions. Thank you very much for your time and consideration.
We do have a question. Representative Abramson.
Thank you, Mr. Chair, and thank you for taking my question. Just like the last bill, do you have an estimate for how much you think this might increase the costs for premiums as a percentage basis?
It's a great question. I don't, but I can say that the way the bill is written, it is very broad. So this would impact prior authorizations and drugs across the board, services across the board. So it has the potential to touch every single service or prescription medication that a patient might receive.
Great. Seeing no more questions, thank you very much.
Thank you.
I will next call on Nancy Efferson Bonaccia. Let me see. So if she would just raise her hand. There you go. And I can promote you to panelist. And there you are, hopefully. Are you there, Nancy? You're muted.
Am I unmuted now?
You're unmuted now. You're good.
Okay. Good morning. My name is Nancy Efferson Bonachea. I'm a retina specialist, which is a subspecialist within ophthalmology. I practice in Bedford, New Hampshire. I've been here in New Hampshire for almost 16 years. And I was notified about this bill yesterday, and I wanted to weigh in on the bill itself, but the broader issue of prior authorization. I think it's very appropriate that I'm following Heidi Kroll, because I could not disagree more with pretty much everything she said. And I'm going to start by saying retina specialists in the United States are the #1 Medicare billers drug-wise. And that is because we use FDA-approved medications such as Eylea, Lucentis, Beovu, drugs which were designed to treat macular degeneration, diabetic retinopathy, vascular diseases, all of which are sight-threatening and blinding. Without these medications, during my training, for instance, over 25 years ago, we had no effective treatments, and people traditionally went legally blind from their disease. With the advent of these medications over the last 15 years, we've been able to maintain vision in 90% of our wet macular degeneration cases, and we have reduced diabetic blindness, which is the leading reason why young diabetics lose their jobs, go on disability, and are out of the workforce. These drugs are very expensive because they're FDA approved. And over the last 48 months, and as of January 1, the burden on providers in private practice to use these drugs for our patients is prohibitive. Just to use some of her comments that providers have not taken up the offer to discuss issues with medical directors on the use of these drugs is, first of all, not even the issue. They have, as of January 1, for instance, United Healthcare, all of the Medicare Advantage plans across the board have instituted stepwise therapy and prior authorization, and to the point where it takes my solo practice more than one full-time equivalent on the phone all day trying to get prior auths. And we are now being told, and this is all new as of January 1. So when she said give time for these former bills to take effect, January 1 marked the start of all of these Medicare Advantage plans in particular, and the commercial United, Aetna, Cigna, Blue Cross Blue Shield, Harvard Pilgrim Stride, to reverse or let the request that was made by HHS in 2020 because of COVID to back off on prior auths. They let January 1 be the end of all of that arena. And now we are being told that not only do we have to have prior auths for things we didn't used to have, including Avastin, which is the off-label medication they're trying to force us to use instead of Eylea and Lucentis because it's $65. They're actually making us go through a prior auth to get a $65 drug for injection every time the patient comes. And the prior auth, in this bill, the 6-month prior auth, to me, should be the minimum. If you had any idea how long we sit on the phone for a single patient, single prior auth, we're talking sometimes an hour and 45 minutes. And she talked about these electronic options for prior auth. That is a joke because we have a problem in New Hampshire with our Availity website. Most of these plans, we have tried going online. We end up having to go on the phone. As a matter of fact, the carriers themselves tell us the best way to get to them is on the phone, not trying electronically. Then they tell us as of January 1 that they have, well, Humana and others have told us that before, that they have 14 business days to decide whether this patient needs treatment. In the meantime, my patient can go blind, irreversibly blind, and, you know, compounding all of that is now, Ms. Kroll said that prior auths are essential because they're evidence-based therapy and for patient safety. Who is she kidding? We know our academy has been fighting and been in the federal legislation showing that over 90% of every prior auth for intravitreal injections, which is what I'm talking about, is approved. So why are we being delayed care and having to go through this continuous prior auth burden? And Blue Cross Blue Shield, the other, Ms. Dunlap was saying, you know, how Blue Cross Blue Shield is their prior auth is for safety and all this other stuff. They're a perfect example. After fighting and fighting and fighting for prior auth on their patients, we have patients that have been getting injections for 3 years. And every time I do an injection on certain patients, Blue Cross Blue Shield holds up the payment, asks for the records, reviews the treatment. This is after the prior auth procedure. So I know I'm going on and on, but all I can say is Bill 191 to me, forget being broad. It is so specific. It is so limited. The least these patients deserve is a 6-month prior auth. The transfer of care obviously is more of a facility issue. But when it comes to private practice and patient care, my patients are currently in a very, very precarious situation because almost 40% of seniors now are signing on to these Medicare Advantage plans. All of them require prior auths. Now all of them have instituted stepwise therapy, and they are quoting studies. That's the other thing that Ms. Kroll said about evidence-based. They don't know the beginnings of how to interpret these studies. They are taking the studies out of context. They are putting statements in their plans that say that you must show that the patient has failed on Avastin, which is forcing us to use an off-label drug, non-FDA approved with safety issues over FDA-approved drugs in and of itself is unethical. But for them to quote studies saying they're equivalent when they haven't even studied the 15 years of data that's out there that shows that some drugs are superior. And I, after 16 years of training, I like to be the one to decide which drug my patient gets. So with that, I urge you to consider not only approving 191, but really looking into why they're saying premiums are going to go up. They're going to go up for one reason and one reason only, because they're going to have to prior auth the appropriate treatment and drugs of patients, not because they had to have a prior auth procedure to do it. There's absolutely no reason in 191 why any premium should go up. If anything, it should go down if you're getting transfer of care to a less expensive facility and your prior auths are for 6 months, your own staff won't have to be on the phone with providers every day of the week. We now have some Blue Cross Blue Shield people giving us 30 days, one drug, one injection, and making us go back and get another prior auth. So with that, I thank you for your time, and I can take any questions.
Yeah, before I take questions, I'm not sure this legislation is going to affect Medicare or Medicaid.
I did not say Medicare or Medicaid. As a matter of fact, I wish the problem this bill will affect is your commercial Medicare, Medicaid replacement plans, because they run under, they are commercial and their prior auths Medicare does not require prior auths.
Okay. All right. Any other questions from the committee? Seeing none, we thank you very much for your testimony.
Thanks.
Okay, next up is Ellen Wood. Also, she's from Seacoast General. So Ellen, if you just, okay, there you are. And we need a panelist, and you are on. And you're still muted. There you go.
Hi. Okay. Thanks so much for this opportunity. I don't know. Oh, I can start a video too. Okay. I'm a practice manager for a general surgery practice, and I've been working with them for 17 years. And I would concur so much of what Nancy just said. Again, we're general surgery, so it's very different than ophthalmology. But pre-authorization at this point, Anthem uses a company by the name of AIM, and I am not exaggerating when I say I have a staff member that will be on the phone for 2 or 3 hours waiting for a representative. And you're not getting a representative that is knowledgeable for the most part. They're just taking the data, not really even aware of the data they're taking. Many times we do MRI for breast cancer, and they're wearing blinders. They have little to no medical experience, and they're making a lot of times the determination about whether this auth is expedited or not. You know, a woman's waiting for her MRI because her pathology has said that she has a possibly invasive breast cancer. And it's really, it's time consuming, a waste of time for many of the authorizations. And there's little to no value. I would like to talk about when they're talking about the increase of costs. I've been in the business for a long time, and my understanding was that they put authorizations in place to save money. So I think it's sort of interesting that now they're saying it's going to cost money. I'll also address the fact that she's mentioning something about calling them or discussing it with the medical director. That is, I've done it for a procedure that continually got denied, but it took me over a year to try to finally get somebody that would understand what it was that they were denying that made no sense. And at no point did I ever fully get to the medical director, and this was Anthem. United Healthcare, for the second procedure piece of it, United Healthcare uses a company by the name of Optum. So you have to send the claim in, then they say, you know, nope, you didn't auth the second procedure. We need notes. And we'll send notes in, and I can't tell you how many times, sometimes 2 or 3 times, and I'm not exaggerating, that we will fax the whole record for this patient to get the surgery paid for. At 50%, mind you, because it's the second procedure, so more often than not, since they figure you're in there, then they're only going to pay you at 50%. You don't get somebody that is English is their primary language. And those are the people that most likely are reviewing our medical records. And that's disappointing, to say the least. The other thing is, a long time ago, there was, and I would challenge the insurance companies for their, you know, what are they using as data? Because a long time ago, they had data that said if a provider's office continually did a pre-authorization and got approved, and I would tell you less than 1% of our pre-authorizations are denied in general surgery. So in my practice, in any event, which tells me that my doctors are doing nothing but medical necessity surgeries and medical necessity procedures. But anyway, there was a carrier, I think it might have even been Cigna, that would give a practice or a provider almost like a gold card. So they didn't have to go through the pre-auths again and again and again, when in fact they had a proven track record of getting all their pre-auths approved at 100% because everything that they did was necessary. And then they followed through maybe with the operative note to, you know, with the ICD-10 codes and the procedure codes. I don't know why that was thrown out, and I don't even remember, but it was a long time ago, but it was something worthwhile. And I would tell you, just recently, we had somebody with Medicaid, and her prior auth was approved, but for some reason, maybe the gal couldn't get to, it was an MRI for her breast, and she had breast cancer, but she couldn't get to her appointment, and possibly the hospital was delayed because of COVID, and recently they were packed. And so that was a condition too. And of course, we're getting patients that cancel because they're afraid to go to the hospital. But anyway, her prior auth was expired by 1 day. My staff member had to start from scratch to get her prior auth approved again. Is that a good utilization of expertise or time? It's not. That's insane. But you know, that companies say, well, I'm sorry, we can't transfer all that information. You have to start from scratch. I have no idea with anybody with an ounce of intelligence would put that procedure in place. It makes no sense. And that's basically it. I think to extend it to 6 months at the very least is, especially in this climate, should go without saying. And don't believe everything you hear from the big insurance companies. Thanks very much.
Okay, do we have any questions from the committee members? Seeing none, we are running a little bit behind here. So next I'll call on Nick Canaro. And Nick, you raise your hand. And oh, there he is. Okay. Go ahead.
Thank you, Representative Hunt. Can you hear me?
Yes, I can.
All right, I was on there. I've signed in as support, but I was kind of a placeholder in case Paula Minahan couldn't get on. So I fully support what she said, but other than that, I have no further comment. Thank you.
Okay. All right, great. Thank you. And now we have Ahad Fazlat. Fazlat? Is he on? If you're on, Azad, just well, he's an A, so he should be right up here unless he's this phone number. Azad, are you on? Said he wanted to speak. Going once, going twice. I don't see him. Okay. How about Cynthia Martin? There you go. And promote to panelist. And you're on, Cynthia. Cindy, excuse me. Cynthia here. And you just have to unmute yourself.
There we go. Can you hear me?
Yes.
Okay, wonderful. I am so happy to be able to say something about this issue. I appreciate having 3 minutes to talk about an issue that I've watched just unfold over my 30 years as a practice manager in multiple offices. I right now am managing the practice of a retina specialist in Bedford, Dr. Nancy Bonachea. And the other practice manager, Ms. Wood, I cannot tell you, I cannot stress enough of what they speak of and how unbelievable this prior authorization process is. Every single thing that they said, I kept writing notes and I'm like, yes, everybody that we talk to, I'm on the phone. I talk to these people. They don't know what they're authorizing. They don't even know what they're talking about. The inefficiencies in the utilization management programs that they speak of is unfathomable. The urgent, emergent rush of a PA that's necessary, the soonest you can get it is 72 hours. It's unbelievable what has happened and how things have deteriorated. And especially when I work in retina specialty now, where we're talking about sight, people's eyesight, not that I'm putting anything, the cancer, the breast cancers, but the people's vision. If your sight was threatened or that of a loved one, and you couldn't get the treatment that you needed because of a prior authorization for a treatment, it's criminal. It's absolutely criminal. So I know we don't have a lot of time. I just wanted to reiterate that I experience daily what these people are speaking to. And I say bravo to anyone that is going to listen to the physicians who have the expertise and the knowledge. They are the ones that need to determine the care, the level of care that their patients need, not some insurance company or person behind the phone that has absolutely no experience. Thank you.
Thank you. Anybody else would like to testify, ask a question? Seeing none? Okay. Tyler, you're raising your hand.
Yeah, I believed I was registered to testify.
Yes. Yeah. No, I still was going to come. I was going to have you wrap up at the end here. So I got two more people to speak. Okay. So next is David Hutton. So David, if you just raise your hand, then I can find you. And I don't see any raised hand. So one more chance. No. Okay. So last lobbyist before I have Tyler is Maura Weston. Did I? Yeah, Maura. Did I have you speak yet? Yeah. Okay. Here we go. There you go, Maura. Good morning. You have to unmute yourself, Maura.
Thank you. Can you hear me?
Yes, I can.
Okay, I'm sorry for that. Thank you very much. Good morning, Mr. Chair, members of the committee. My name is Maura Weston, and I'm here today to testify on behalf of Derry Medical. Tom Buchanan, the CEO of Derry Medical, had hoped to testify today. However, he's currently testifying in another committee. So you get the B team, and I'll do my best. I'm here this morning to express support for House Bill 191, but we would like to encourage the committee to consider an amendment to actually expand its application. Derry Medical Center is an independent 60-provider primary care physician group in Southern New Hampshire. We see about 45,000 patients, and on average, we see about 1,000 people a day. We believe that prior authorizations have turned into a burdensome function that drives up costs, reduces consumer choice, and operates outside the general view of insurance regulations. While this bill is a good start, we don't think it goes far enough. Possible changes that would strengthen consumer protections and reduce administrative burdens would include a couple of different ideas that we have. First, all clinical prior auth guidelines used to make clinical determinations to cover services need to be available to the contracted provider. All too often, lower level employees in health plans render decisions that are not consistent with appropriate medical guidelines. This forces peer-to-peer to peer discussions, which are time-consuming for physicians and not the highest and best use of the provider's time. Outside of that physician time, Derry Medical employs 5 people solely for the purpose of handling prior authorizations. We need those prior auth guidelines, and they need to be accessible, and they are not. For an entity like Derry Medical, the prior authorization process is real money. It's a real expense. We pride ourselves on being a low-cost, high-quality provider. Generally, our cost of patient care is on average 15% below other providers in the state. In an outpatient primary care setting like Derry Medical, our patients seek the best medical treatment options, and we seek prior authorizations for their care with any number of different providers and facilities. Prior authorizations should not be a tool to reduce competition and keep a patient beholden to a certain healthcare system. Prior auths for diagnostic testing should be provider agnostic. This means an approved diagnostic study should allow the patient to go to any contracted provider for that service. Currently, the prior auth process requires the name of the facility to be included in the prior auth approval. Patients have little choice of where to go, and if they want that changed, it's cumbersome, and many originating providers are unwilling to change it. In the age of $6,000 to $12,000 deductibles, patients should have the right to go where they want within a plan network, especially given the range of pricing that exists in New Hampshire that the patient is liable for. Therefore, we encourage the committee to expand the conversation around prior authorizations. We would be happy to work with the sponsors in the committee on prior authorization reform, and specifically on language relative to prior authorization portability. We believe that this step would increase transparency and allow for greater consumer choice in their healthcare decision-making and reduce the total overall costs of healthcare services in New Hampshire. Thank you for your time.
Thank you. You willing to take a question?
Sure.
Representative Petusik has a question.
Thank you, Ms. Weston. Representative John Petusik, Derry, New Hampshire.
Good morning.
Good morning. A patient at Derry Medical Center of Dr. John Wheeler.
Fabulous.
I saw on my email before I ran upstairs here that you have submitted an email testimony to us.
Yes.
Is your recommendations, or are your recommendations for expanded portability and those issues in that email? I didn't have a chance to read it.
Yes, thank you for the question. The written testimony is more of a summary. My oral comments went a bit beyond that, and we did not provide a proposed amendment in the written remarks, but I am happy to work on some language and submit it for consideration.
Well, thank you very much.
Certainly.
But we do have one more hand that just came up. We have Dr. Brewster, and Bill, I'm going to promote you to panelist. So and he's are you former medical director? Are you still the medical director of Harvard, Bill?
Can you hear me now?
Yes, there you go. Perfect.
So first off, I want to apologize. I don't normally bring my dogs to hearings, but I have 2 of them and they're usually quietest when they sit next to me. So I apologize. They bark. Good morning, Chairman Hunt, Vice Chair Petusik, and members of the committee. My name, for the record, is Bill Brewster. I'm Vice President of New Hampshire Market for Harvard Pilgrim Healthcare, a not-for-profit health services company. I previously served as Harvard Pilgrim's Medical Director for New Hampshire, overseeing the evaluation of medical necessity, appropriateness, and efficiency of healthcare services for all of our members. I'm also a board-certified internal medicine doc who practiced in New Hampshire from 1987 to 2018, and I've also served on the board of 2 nonprofit hospitals in New Hampshire. Thank you for giving me the time to speak to you this morning on House Bill 191. I have a lot of concerns with the bill and how it will impact how we manage the care of our members. First, the bill requires all prior auths to be valid for 6 months. 6 months is not appropriate for all services or treatments. In fact, sometimes it's not even long enough. And we will routinely give 1-year approvals for many of the drugs where the condition isn't expected to change. It's going to continue. All of our prior auths are service or treatment specific. They address what is a typical length of time that somebody might need to be in an acute rehab or hospital. Again, just to reassure everybody, it's not gotcha medicine. It's not arbitrary. We really do, based on input from published evidence-based medicine and clinical experts. When we have prior auths, you'll see a site at the bottom, all the list of the different articles that we reviewed, so that if somebody has a concern about that, we can address it. We also try to make prior auths easy. We offer an electronic prior auth process. And if something gets moved out, I heard that commented on, if something does get pushed out because of COVID or prior to COVID, there were reasons why things had to be moved out. And all the provider needs to do is change the date in the electronic prior auth. It doesn't need to be reauthorized. Again, to try to make it easier for the providers. As far as the last section of the bill on patient transfers, we consider any request to transfer a patient to a low level of care as an urgent pre-service request. All of the requests are reviewed within 24 to 48 hours per NCQA. NCQA is the National Committee for Quality Assurance. It's a nonprofit that uses evidence-based medicine that we all have to adhere to be credentialed. One of the only prior auth that we have is on authorization to transport somebody to a lower level of care. Again, I think Paula and others had mentioned that transfers from acute hospital to acute hospital, from Frisbee where I work to Portsmouth or Mass General, we don't require any prior auth for that. But any that is an elective, non-emergency transfer, if somebody's using an ambulance, we ask for a medical justification for why they need an ambulance rather than a wheelchair van. And we'll approve it if in fact that they can't be in a wheelchair or they can't be transported safely that way. And again, frankly, I mean, you can all imagine, we don't want members to be in acute care any longer than necessary. Having a bed full, I've been on diversion at hospitals, I've had to move people around. We want people to be able to get into the hospital when they need to get into. We need them to get to a lower level of care when that's appropriate as well. I'm personally, and I know we as a company are happy to continue to work with the hospitals if they have specific concerns about how we do things. But I haven't had specific examples to really be able to address or fix a problem if there is one, and would like to continue to work with them outside of the legislative arena if possible. Again, I tell my staff it's not our money, it's your money. If you're a member of ours, it's the employer's money. We need to manage that responsibly. We need to try to keep the cost of care as affordable as possible. And broad limits on what plans can do in this space will only serve to increase costs for members. And for all of those reasons, I urge you to find Senate Bill 191 inexpedient to legislate. Thank you for your time and happy to take any questions.
Well, I thought we had a question, but Representative Matusik put his hand down, so I guess we're all set.
Thank you so much.
Thank you very much for weighing in. Okay, now Tyler, I'll have you wrap up for us.
Thank you. So Tyler Brennan with the New Hampshire Insurance Department, and we don't have a position on the bill. First thing I want to do is clarify, I think one of the questions that came up, this would be a insurance change. And so it would not apply to the Medicare Advantage plans, which are regulated by the federal government. It would also not apply to the managed care organizations that are under contract with DHHS for Medicaid. As usual, it would also not apply to self-funded populations that are using a carrier like Anthem to administer their benefits. This is typically the case when we have commercial insurance legislation. One of the first things I noticed about this legislation that's a little different is it's general, applies to all services, products. It's in the statute, in the managed care statute, that would apply to any network-based products. when you look at the other prior authorization restrictions or areas in statute, they're all targeting certain types of services or providers or circumstances, such as obstetrical care, mental health services, something like that. So it's unusual to see something that would be as broad as this legislation would be. I actually can't think of another prior authorization change that would be as broad. Generally speaking, with legislation like this would weaken a carrier's ability to perform utilization management, case management through prior authorization. And certainly we hear kind of some of the frustrations in the provider community. Prior authorization is a utilization management tool that does control cost to an extent. So despite what might be inefficiencies, doing away with it or restricting it, we should see some inflationary pressure on healthcare claims costs and in turn our premiums. It is worth also recognizing, and I think it's been mentioned, but maybe not perfectly clear, sometimes prior authorization is always granted. It's just a part of the administrative process of a carrier flagging a particular patient, so they can use case managers, they can coordinate care, they can be involved. We have to remember that sometimes when you go to a hospital or you go to another healthcare provider, the insurer may not know about it until the claim comes in without some sort of prior authorization process. The other reality is that healthcare findings do change sometimes quickly. It could be a service is now deemed high risk for a particular population, or maybe it's even high risk within a particular provider setting. The other consideration is an insurer tends to be able to see kind of a bird's eye view of a patient's healthcare experience. So something like a number of CT scans or something that just has a lot of radiation exposure over time, maybe being done by different providers, that's not something an individual provider may be aware of, but a carrier could implement tracking and identifying those types of services. So that's most of it as it relates to the prior auth. There is the second segment that does deal with the transfers. And I thought this was also perhaps trying to target particular circumstances, such as people being in the ER or otherwise held up. And because intuitively a carrier has a business interest in transferring a patient to a lower cost setting. The language makes me a little bit uncomfortable because it could be open to interpretation. It does make reference to the carrier not providing accommodations, and that's a little unclear exactly what that means. And then, of course, paying the per day rate, where that assumes that the patient there is receiving services that are paid on a per day. So it sounded initially, it looked like it was intended to target very specific circumstances, but I couldn't actually understand what providing accommodations could mean in every context. So as a regulator that would be enforcing the requirement, that's a little less clear than what we would ideally like. So that's probably everything I can cover that would be helpful. Happy to answer any questions though you might have.
I don't see any. Okay, Representative Gable, just a question.
Yes, thank you again for your testimony. We've heard two kinds of testimony today. Insurance companies, representatives saying that prior authorization reduces costs and improves care, and people representing various healthcare providers saying just the opposite. And it's almost like two statements of faith. But I wonder if you or any of the other people who have testified could, after this hearing, could send us some documentary evidence to support that it either increases costs or decreases costs. I just don't know if I want to believe it just because people said it. So my question is, if anyone can do this, would you please get back to us with evidence that in fact it is saving cost, it's not saving cost. It is improving care, it's not improving care from whatever studies. Thank you very much.
You want to?
I think along these lines, one thing I would kind of add is that this is a competitive area, that one carrier may actually manage their prior authorization better than another carrier, which means that they're going to reap the benefits of doing it in a better, more efficient way. I think to the extent there's a debate about whether or not it saves in general, I mean, clearly the carriers would have a business interest in reducing their claims costs as much as possible. It may not be public information, but I think if you were to sort of explore some of the discussions between a large provider delivery system and a carrier about assuming risk for healthcare services, think capitation, accountable care organizations, other sort of global budgets, providers are often a little bit uncomfortable assuming responsibility for utilization management and prior authorization. If a carrier has passed all their risk to the provider, then they're less interested. So that may be kind of an interesting area to explore to the extent that who is actually at risk for these claims expenditures and whether or not prior authorization or other medical management tools are used.
Representative Aberson has a question.
The mute button. Thank you, Mr. Chair, and thank you for taking my question. You lower my hand. Is there a way to amend this bill to remove some of the problems and issues that were brought up, but still retaining the protection for prior authorization so that prior authorizations still remain valid?
I would say yes. I mean, I think that there are ways to modify the bill to perhaps give the flexibility that is necessary or helpful to a carrier. But I think at the end of the day, it's going to be a compromise one way or another. As I started with, it may be worth exploring whether or not the issues are most acute in particular settings or particular providers, or whether, considerations for what is most efficient that a carrier is doing. But clearly every bill could be made a little bit better.
Well said. Representative Terry has a question.
Thank you, Mr. Chairman. Commissioner Brannan, we've heard from a number of individuals today who have expressed frustration in dealing with receiving prior authorization for medications and services. In your role as Commissioner of the department, have you received the same sorts of complaints from providers, and to what extent have you received those and how have you addressed them?
So the insurance department's primary focus is consumers. So to the extent complaints come in from a consumer, those are the ones we prioritize. And indeed, we have received complaints in the past about sort of getting access to healthcare services and potentially a carrier feeling differently about a potential treatment being prescribed for a particular member than the provider does. There are actually several levels of sort of appeals that a consumer can go through to deal with barriers being put up by a carrier, and some of those are actually in statutes. So we do try to handle these as efficiently as we can, but at the end of the day, you do end up with some disagreement occasionally between a provider and a carrier. That being said, the sort of external appeal process actually does allow a medical care provider outside of the department and not involved in the dispute to weigh in on medical necessity and the treatment that's being intended.
A follow-up, please.
Further question may inquire.
Thank you. With respect to the appeals process, would you characterize the approximate length of time for most of those appeals to be heard and resolved? And do you find that the appeals process is adequate to remedy most of the complaints from consumers?
Yeah, I'm not sure I could weigh in on the average time it takes to resolve a dispute, but there is a expedited appeal process which has to be resolved within either 48 or 72, I believe, hours. But in general, I think there is a fair amount of sort of comfort with those protections, and I don't think we've seen legislation to change the appeals process for quite a while. So I think that would suggest that it's working as intended.
Great, thank you very much. All right, now I think we're done now for, I don't know, I got another hand went up. Miss Wood, we're really kind of full up now, but you can certainly submit some more testimony if you want, like if anybody has any more comments they want to make, please feel free to send stuff in. And with that, I will close the public hearing. And because we're now really behind, but on a somewhat similar subject. So we'll go right into it. And Patrick, Pat, I see you get your hand up, so I'm going to promote him up to panelists. And we'll open up the public hearing on 165 and hear from Representative Brahmi. Good morning, Representative Brahmi, and I'm sorry about the delay.
Thank you, Mr. Chair. For the record, State Rep. Pat Brahmi, Rockingham 19 Stratham.
Yeah, Pat, we had the same problem before. You
Yeah, I
gotta
know.
talk louder, you know.
I've for a while it was good. Now I was just told this morning on Ways and Means that it was out. I'm
You're
just
still-
glad to speak up. I've tried every setting.
Get closer. Just get closer.
I'm as close as I'm gonna. So you're gonna see my. Hope you don't see my face.
We don't see anything, so.
The camera. Okay, good. That's good. So
Go ahead.
Again, this bill is identical to a bill that I had filed last term. At that time, it went to the Labor Committee, where it passed unanimous, and on the floor in the consent calendar. And again, like hundreds of other bills, it never had a hearing, and it wound up tabled. So I refiled this bill. Mr. Chair, can I ask a question? Is this an early bill? Is this going to go to Labor, or you
This
folks
is
handling it?
not an early bill, no.
Okay, just want to understand. Thank you. So I was approached by several mental health practitioners who want to come out from underneath non-compete clauses in their employment contracts. Just for clarity, there are 5 license types that would come under this bill. 4 fall under RSA 330-A. That's pastoral psychotherapists, clinical social workers, clinical mental health counselors, marriage and family therapists. And then there's one that falls under RSA 329-B, psychologists. Members of this committee who have been around for a while may remember that we have done similar things for other health professionals. In 2016, we did a similar thing and created, we got physicians and surgeons out from underneath the non-compete clauses. And that is in statute RSA 329:31-A. Then in 2018, we did the same for nurses and podiatrists. The nurses are under RSA 326-B:45A, and the podiatrists are under RSA 315:18. What I want to point out is that if you go to those statutes, you'll see that the language that I have in this bill is identical to those 4 professions. Okay, just understand that. So I just stole that language, and was the language that is in these statutes. So that the language has been tested over a number of years now. This bill's language, as it did for physicians, nurses, podiatrists, et cetera, only applies to new contracts or renewals of contracts entered into on or after the effective date of this section. So you may say, well, why mental health workers now? There's a few points. We're in the midst of a mental health and addiction epidemic. These mental health workers are a lifeline to their clients. There's a true practitioner-client relationship between them. If these practitioners want to advance in their careers and move on to another practice in a geographic area, many current contracts prevent them from doing so. The norm that you see is a 30-mile radius. You can work outside that 30-mile radius. And in many of those cases, they would have to sever the relationship with their clients. So that is the basic bill. But basically it was the House position last year. I know we have a new House, so there are many. I know there's several practitioners who are going to be testifying behind me. Mr. Chair, I'm willing to take questions, but when it comes to more specifics about the situation, I'm sure those others would do a better job than I testifying. But I'll take any questions if there are any.
Yes, Representative Herbert has a question. You're muted, Chris.
Thank you, Chairman Hunt, and thank you, Representative Abrami. My question is, actually, I can't believe it, but I'm kind of stealing Max's question. Have you noticed in the other non-competes that you proposed and got passed that it increased costs or decreased costs, or what were the impacts, the real world impacts that you may be aware of from the non-competes that you already, I don't know if you limited them, you limited their application?
Okay, well, first I want to say hello to Representative Herbert, who was on the Ways and Means with me for a term or two. So understand that the physicians, surgeons, nurses, podiatrists, I had nothing to do with. That there were other people who filed those bills. I think in 2018 it was Senator Sanborn's bill that was passed. So as far as any negative or positive impacts, I don't know. I don't have the answer to that.
Okay. Seeing no questions, so I'm sorry about the delay. And I'd say in hindsight, I wish I totally missed what this bill was about. I see it's a non-compete. Somehow I had it was a prior auth bill, but
Representative Font, I should have called you and say if we could.
should have called me. I would have had it vacated in a heartbeat, but
yeah, but we're not in session for a while. I don't know. Can we vacate without being in session, or does that have to go to the floor?
No, the hearing's already been happened, so you
All right,
can't vacate now. So.
Well, okay, well, have fun with it.
Hindsight is 2020, but next time.
Okay,
Call me ahead.
You'll be in good hands with those testifying after me. I'm heading back to Ways and Means now. Thank you.
All right, thank you.
Bye-bye.
Okay, so I'll now call on Carrie Jason must be a French name, yeah. And I am going to allow. Yeah, here we go. Promoting the panelists, Carrie, and welcome to the Commerce Committee. And you do have to unmute yourself.
Okay. All right. I think here I am. Hi there. Yes, I'm Dr. Carrie Chasen. Thank you guys for giving us some time today to chat about this issue. I'm my version of when we testified on this bill last time it was heard. I basically just was here to tell my personal story, and because I was directly affected by a non-compete that really impacted my life in a really negative way that I have turned around into things are fine now, but it messed things up. So I'm here to just tell my story. So I'm a licensed clinical psychologist who moved to New Hampshire from Rhode Island, where I had been in a private practice, to New Hampshire to be closer to my husband's and my family. That was now a few years ago. And in order to accept an offer from this single owner private practice in Portsmouth, I was required to sign a contract and non-compete, non-solicitation that dictated that currently and for 2 years after my employment ends, I cannot practice psychotherapy at a private practice, group practice, hospital, or medical center within a 30-mile radius of the office, which I negotiated down from 40 miles. The owners and my goal had been to work full-time, so scheduling approximately 25 to 35 people per week. To initially help build my practice, I made calls to local professionals to network. I wrote pieces for the practice's monthly blog, provided free talks at a local community center, and spoke to parents at a school, at schools for presentations. After having been there for almost 10 months, my schedule was not even close to being full. In my best week, I saw 15 people, which happened twice, and they were in my third month of employment. The mean was I saw about 10 people per week, and I still only worked 3 days because that's how I started things out. I had been actively involved in doing what she had asked as a way to increase my caseload, talks, written materials for the blog, a Parenting New Hampshire article, made phone calls to other professionals in the area, and similar things. We had 2 meetings where a couple months apart, where I had asked to meet to discuss ways to increase my income, including taking in-network clients, which she said I was not permitted to do. It was a practice where we were only, we didn't accept insurance, and she wasn't willing to let that happen for me in this situation. After about 10 months of working there, I was approached about a part-time opportunity to work at UNH's counseling center as a way to supplement my income on a temporary basis while I wasn't making a sufficient amount of money. The position was offered as a staff psychologist, where I would be available to meet with students on an as-needed basis, and I was just going to do it the other 2 days of the week that I wasn't already previously committed to my current practice. I would have been paid hourly by UNH from fees included in every student's tuition, not by individual clients or by insurance. I told my boss about the opportunity, how it could fill in my available time while I continued to build my client base at her practice, and how I could even forward potential clients to her practice if they wanted private services, as sometimes counseling centers can get overwhelmed. And I explained how it would not negatively impact her business, and it seemed to me that it would only be a positive change. My boss believed that it was in conflict with my non-compete because it meant providing psychotherapy within the 30-mile radius, and so was not okay with my taking the job. I saw no conflict. My compete did not mention university staff positions. Also, the clients would be completely separate. It was drawing from an entirely different pool of individuals. Clients at UNH pay nothing to be seen on campus, and they would have had to pay $150 a session to be seen by me at the private practice. And that fee is included in UNH's tuition. Later that month, she proposed an alternate idea, and that was to have my boss contract my services out to UNH. So I would remain her employee, so that the income from my 2 days working on campus would come from UNH into her practice, meaning my boss would take a cut before I got paid. UNH and I were both very unwilling to do that. And so basically I decided I was ready to leave to look for opportunities, and I hired a lawyer to check to see like how stuck would I be if I tried to find a job within 30 miles. But the lawyer that I hired was not convinced that she would not come after me if I tried to work within the radius, and she had, enough grounds to probably be able to do so. Given my financial state, I chose not to take the risk and instead found something outside. So I now work in Nashua. I'm very happy where I am. But after finding that new job, I was commuting 50 miles each way, 5 days a week for work until I moved my family again. So, and I had a 2-year-old at home at the time, and I was working long days and was driving really far, all because my boss had an issue with my trying, to make enough money. And if it meant that she wasn't taking a piece of what I could get. And actually in this situation, there's one more little piece to it that my boss also, my old boss also had an issue with how a few clients of mine wanted to follow me. Even those that had a long-term relationship with me and I had, helped sufficiently. I'm also highly trained in treating OCD and anxiety disorders, which is a pretty specialized, especially OCD is a pretty specialized treatment group. And so I was making a name for myself in Portsmouth, and then to have to say, okay, anybody who's looking for me, now I'm going to be in Nashua. Good luck making that drive. So it really, I think it impacted, the mental health of some people there, as well, because I needed to essentially prematurely stop treatment with clients. And I did my best to try to find them other people. I don't think there were any concerns of abandonment, but, it meant that she was making things really difficult. And if I had not had to move and go so far away, I could have found a different place to work and continued seeing those patients in that area. So I don't know. I mean, I think this, this bill won't actually even directly affect me. I know that it's not going to be for retroactive ones, and that's fine. I actually only even have 4 months left on my non-compete anyway. But it's still important enough to me that other mental health practitioners don't end up in this same situation, both for the practitioners, but also for the patients that they treat. You know, I mean, we develop, you know, sometimes really close, sometimes life-saving relationships with patients. And it's really unfortunate that sometimes if somebody's unhappy in their job for whatever reason, that they need to end and, you know, they need to sever those relationships, you know, is really pretty terrible. So, you know, I think it's detrimental to patients if their clinician is forced to move, if she's unhappy in her job. You know, mental health services are limited enough in our state, and I feel like we should not make it even more challenging for people to get and continue their care. You know, unnecessary disruptions in care could have been prevented if I had not been held to my non-compete. So that's basically the end of what I have to say, but I'll take any questions if anybody has any for me. So
Representative Abramson has a question.
Thank you, and for your testimony, and thank you for taking my question. I wonder if, I know that some businesses need to have non-competes in order to be able to invest in a professional in some way or to hire them. I've faced non-competes and I chose not to sign them. I wonder if there's some way that we can put like some type of limitation or a buyout, guaranteed buyout, so that if someone's facing an old non-compete, that they're guaranteed an ability to just buy out by paying a certain amount of money, as though they're kind of paying the other person back. Because sometimes the other party holding on to the non-compete will say, oh, this was much more valuable than anything I suggested when we first signed the contract. In other words, if it was, I don't know, say a few $1,000s or some amount that you were guaranteed to be able to buy out of a non-compete as a professional.
I mean, that would have made my situation better, you know, I mean, you know, it's still, and I understand, I mean, and I think this, you know, I don't know. I mean, I, you know, it certainly would have made a difference for me because I probably would not have moved my family again. And I probably would have stayed in the area if I could have just, you know, gotten out of the non-compete. It's, I don't know, I guess to me in my situation, it was just, it was a lame sounding statement, but an unfair advantage that my boss had. You know, and I even had looked, you know, I felt like I had looked into the non-compete prior to signing it, you know, wondering, is this going to be able to be held up? And upon originally checking it out, I was like, I don't know, like, I'm not sure that she can keep me from doing my job, but apparently she can keep me from doing my job, at least within a 30-mile radius.
Okay, great. Representative Amidon has a question. Keith, you have a question?
Yeah, I just had a question. I'm going to keep it short. You read the contract and signed the contract.
I did.
You committed to the contract, correct?
Yes.
Okay.
It was a huge
That's my
mistake, but I
question.
did.
Thank you.
Okay, thank you very much, Karen. And I have Daisy Cassidy already promoted. So Daisy, if you just unmute, you can and turn your camera back on, turn your camera on, we can see you. And
Putting my camera on. Got it. Okay, there we go. Hi.
Hello.
Hi, thanks for being here. My name is Daisy Cassidy. I'm a licensed independent clinical social worker. So I'm a therapist at a group practice in Dover. About 2 years ago, I started working there, and as part of my employment agreement was asked to sign a non-compete clause. My first thought upon reading it was how it would potentially impact me personally. I would not be able to work at all for between 6 months and 2 years, depending on how long I had been at the practice within a 25-mile radius of Dover. That would mean that if I left, my clients would no longer be able to see me, and I could not work in places like Portsmouth, Dover, Rochester, Exeter, Newmarket, Durham, or Hampton, which are some of the larger cities or towns in the state, and all within reasonable driving distance of my home. In the process of thinking about this bill and preparing to get support for it, I talked with therapists who had signed non-competes and had to get relicensed in another state or commute up to an hour in order to avoid being sued by their employers when they decided to leave. It is possible that they could have prevailed in court if they had been sued, proving that it placed undue hardship on their ability to find employment. However, some may not have been able to afford a lawyer or were convinced that they would not win, so they decided to let it go. Or they were intimidated by the prospect of being sued and as a result felt unable to leave their current positions despite a desire to do so. Some of those people wanted to be here today but could not because they were also asked to sign non-disclosure statements when they did leave or as part of a settlement after contesting a non-compete. Some of them who are considering leaving their current practices are afraid their public testimony would make their situations more precarious. There is a larger, more important issue, however, beyond the undue hardship for therapists should they decide to change employers or relocate their practices. It is an ethical issue, one which concerns our professional responsibilities toward the people we serve. I will speak to the NASW Code of Ethics here since I am a social worker, but all the other professional groups, including the American Psychiatric and American Psychological Association and the American Counseling Association, have their own version of this standard. Our number one ethical responsibility is to the well-being of our clients. Of course, we also have responsibilities to the institutions where we work. After all, without the mental health centers and practices that serve our communities, many of those clients would not have access to treatment at all. However, the ethical code demands that a therapist's primary responsibility be to the people who have entrusted their most private lives to us. Patients who have invested hours and hours, possibly years, building a relationship with their therapist so that we can support them in making positive change, developing healthy relationships, healing from trauma, and in some cases, staying alive. Though there are many reasons why patient and therapist may need to end treatment, to sever that relationship unnecessarily is irresponsible and unethical. It is not a trivial thing to make the decision to seek help from a mental health professional. For some, it may be a relationship of last resort. In the best case scenario, a client has the motivation and fortitude and is lucky enough to find another therapist who is a good match for them quickly and to begin building trust in a new relationship. The worst case scenario is that a suicidal client has an interruption in care that proves fatal. I'm sure most of us here are aware of the troubling state of mental health care in New Hampshire. The vast majority of mental illness in our state and in the rest of the country still goes untreated. And not unlike in the adjacent medical professions, the longer illnesses go unaddressed, the more expensive the treatment is likely to become, and the more damage may be done to lives, families, and communities. Yet wait lists to get treatment at community mental health centers and private practices can be months long. This has only increased over the last year. And if predictions about an impending mental health crisis come true, although some would argue there's already one, and there has been for a long time, finding timely care will be even harder. As of now, I personally am booked solid for the next 2 months and have a wait list stretching into May. Current clients are needing more frequent appointments. Clients who had switched to monthly check-ins are asking to be seen more frequently again. And therapists are having to turn people away because they just don't have room for anybody new. So in reality, there is no danger of New Hampshire mental health centers and group practices running out of business. There is, however, danger for those we serve, especially for people dealing with severe mental illness. We should not limit the ability of therapists to continue to see their existing clients or their availability for those who are still waiting to get care. That's all. Thank you.
Great. Thank you. Sorry to do this to you, but I was so shocked when I realized what this bill was really about. And the only time I've actually really heard about it, because I know we passed the non-compete over the years, was the classic example that I was told years ago was that a lawyer goes to work for a law office and they spend, they're promoting the lawyer. He's an expert in this, whatever. And they do spend some money, help promoting that person. And the lawyer gets a big client list. Mm-hmm. And it says, okay, I'm leaving and now I want to go start my own practice. and basically takes his clients with him.
Mhm.
So would that be true for mental health professionals, that an employer would spend money to help promote you, help you build up that your list simply word of mouth, or does that your employer have a potential people came and found you because of who you were working with, and now you're kind of taking their clients,
Yeah, I mean, I think beyond putting me on the website and printing out business cards, my practice has been built up based on word of mouth and my abilities in professionalism as a therapist.
Okay, fair enough. All righty, thank you very much. I have one other person, AJ DeMonte.
Oh, that's my husband. I put him on because I wasn't sure if I was going to be able to make it. So you can take him off.
Okay. And then Carrie, has her hand back up again. So I guess I'll just, yes, Carrie, how can I help you?
Hi, yeah, I just wanted to quick respond to your question about, the lawyer building up their, client load and then taking them to go. If a practice owner, we're worried about that part, that's a separate document. That's a non-solicitation. So they can say you can't take your people with you, but a non-compete is in my reading of it, in my understanding of it, is more about you can't then be a lawyer within the 30-mile radius of that.
Right. Okay. Well, that helps explain it to me a little bit.
Yeah. So the so you can't take your people as the non-solicitation. So actually in my current job, I was very clear, and they didn't ask me to sign one, but I would not have signed a non-compete again and will never again. But I was okay signing, agreeing that I won't take patients with me, because that could potentially, harm the practice. Although I'm with Daisy on this one, that it's not likely. There are, we've got clients coming out of our ears, we're up to our eyeballs in it, whereas we're in need of more mental health practitioners. So sorry, that's all. Thank you.
Okay, great. Thank you. My wife needs paper. I think this is okay. Thank you very much. And I will have no one else. We will close the public hearing on House Bill 165. And thank you all for coming in. So we're hopelessly behind, Connie. So I guess, but of course it's good that it's a committee member that we're behind, so we don't have to have an awkward situation. But we'll open up the public hearing on what's our bill number here now?
472.
472. Okay, great. Thank you. And I'll invite you to testify.
Thank you. Thank you, Chair Hunt. And I think it's still morning, so good morning to my Commerce colleagues. For the record, my name is Constance Van Houten. I am the representative of Hillsborough 45, which is Manchester wards 10, 11, and 12, which encompasses the west side of Manchester. It's an honor today to introduce House Bill 472 relative to retroactive denials of previously paid claims. That's kind of a cumbersome list of words, so I will try my best to kind of boil it down a tiny bit. I do know that there are others who are lined up behind me to testify. Hopefully they're still there, because these are people who are practitioners who make appointments, and hopefully they've been able to stay on. At any rate, New Hampshire, just a brief history, New Hampshire law prohibiting insurers from imposing the retroactive denial of a claim previously paid to a healthcare provider, except in certain circumstances, was adopted back in 2002. In that law, the retroactive denial had to be within 18 months. That's a year and a half of the date of the payment of the claim. In 2018, the time restriction was changed to 12 months, still 1 year, for individual health plans and managed care plans. In the last House session, a bill, HB 1484, did pass the House. It reduced the time period to 6 months, stipulating some exceptions to this time requirement, of course. With the advent of COVID, though, as with many other bills, that bill died on the table in the Senate. Current law, therefore, still provides that the time frame for retroactive denial of such previously paid insurance claims is 12 months, 1 year. This means that a year after a healthcare provider has rendered services, in good faith, of course, an insurance company can deny the claim. That's 1 year later. Certainly, the insurer shouldn't have to pay a claim for which it is not liable. However, the insurance company, which itself often has time limits within which you must file your claim, should not take a year to determine that a service was ineligible and take back the reimbursement that it already paid. How difficult it must be for a healthcare provider to recoup the costs from a patient or another insurance company a year later. There are other questions. For example, if an insurer paid a claim in error, should it take a year to figure it out? We're often talking here about large insurance companies with the ability to backtrack and to do this in far less time than 1 year. Another question, is it fair to the healthcare provider that the insurance can basically dock future payments to recoup the claim that was incorrectly made after a year has passed? This is sometimes called the clawback bill for that reason. A year later, they can claw back or take back the money that is rightfully theirs. This is the insurance company about which I speak. It is rightfully theirs. However, they're taking that money from payments that are coming in a year later. House Bill 472, which is the bill before you today, is identical to HB 1484 from the last session. It includes the shortened 6-month time requirement, which in my opinion is probably still too long. It is one of the results of discussions in last session's commission to study the business environment for mental health providers. As I was waiting and listening to the previous testimonies, I got an alert from NPR, which says, and I quote, "Mental health professionals warn the pandemic may be raising suicide risk for many kids. Representative Abrami and other speakers have alluded to the need for quality healthcare, healthcare providers, including mental health providers. And yet we are making it very difficult for them to do the jobs with their clients, with their patients, because they are mired in paperwork trying to take care of this type of an issue." In closing, I would be remiss to say that there aren't a few issues that have been pointed out to me by those who may testify today. They're minor issues and can easily be dealt with. I'll take questions if need be. I know I need to be cognizant of time because the chair put me just before lunch. And so I will take questions. However, the healthcare providers who I hope are still on will be able to deal much better with the questions than I can. Thank you very much for listening to me today.
Okay. Let's see. I do have one other representative. Representative Moran is, if you're there, you can raise your hand. You'll usually do reps first, but then I don't see your hand. Okay, next up, well, I see a hand up and so Heidi Page. So we'll have Heidi Page. You're now welcome to the Commerce Committee. Did I do it right? There you go. Okay. You just have to unmute yourself.
Hi, can you hear me now?
Yep, great.
Okay, great. Thank you for hearing my testimony today. Representative Van Houten, I think you did this bill much justice in how you introduced this. I am Heidi Page. I have a practice providing mental health counseling. My practice is located in Concord, and I have been in private practice for 20 years now. I'm here to speak on this bill on behalf of Clinicians United New Hampshire. We find that these clawbacks are a burden on small business. Practitioners do their due diligence in obtaining patient benefits. They see the patient maybe for one visit or a series of visits, and they bill insurers based on the information insurers gave them. Then they get paid those claims that are to the insurance. End of story. But then months or even years I've seen, in some cases, payments of these payments, clinicians get hit with retroactive denials. I'm not aware of any other industry that pays vendors or consultants, in a sense, and then turns around and takes monies paid back due to their error. Clawbacks are done by withholding payments on current patients we are seeing. This creates an onerous paperwork and tracking nightmare for many practices, especially if there are multiple practitioners at a site. My colleague Sean Hassel is hopefully going to be able to speak more on this today. With a 6-month margin, health insurers who have many more resources than small businesses in New Hampshire should be able to identify mistakes. We prefer that in cases where they find that another insurance was responsible for the claims, that they be limited to 6 months as well as general claims. Right now, there is an exception in the law that is exception number 2E, that states that claims that are the subject of an adjustment with a different insurer can be pulled back to infinity. There is no restriction. If an insurance company, say in 2 years, finds that there was a different insurer responsible, they come after us. They don't come after the insurance company that is responsible. It was responsible for coverage at the time of the data service. So we are asking that the time limit go from the 12 months to the 6-month margin. And we believe that these insurance companies have the resources and the computers in order to be able to do this. And that I would ask that the committee also consider exception E be eliminated, which allows for infinity for the clawback of claims. And with that, I'll take any questions.
Okay, any questions? Yes, Representative Fargo, may inquire.
Thank you, Mr. Chair. A question that has been bothering me is when they hold this money back on old claims, the error is usually on the insurance provider's side. Is that correct?
Yes, they will. We obtain the benefits from them. They give us the benefits, and we see the client and collect copays or deductibles in conjunctions with told us is the patient's coverage, and they pay us. So there is no alarm on our side to say that something's wrong, because we're getting paid as we're seeing the clients.
Follow up.
For the question, may inquire.
So when this happens, is it then your responsibility to go to the patient to collect those monies? Or, I mean, how do you get the reimbursement for what is rightfully yours as a provider?
Thank you for that question. So yes, the idea is that if there is another insurance that was responsible at the time, that we to get the money from that insurance company, which causes a need for a lot of excess resources to go towards tracking that company, filing these claims, retroactive claims, and in some cases trying to go after the client, but the client only seen us for, let's say, 6 sessions, and we haven't seen them for 18 months, and it's very awkward to go back to a client and now try to retract money from them. Oftentimes, as much as 80% of these clawbacks are just written off by the clinician.
Any other questions from committee members?
Thank you.
Okay, seeing none, thank you very, very much for your testimony. All right, next is Deb Warner. Deb, I'm going to promote you to panelist. And you just have to unmute yourself, Deb. There you are.
There we are.
Thank you. Thank you very much. It is an honor to be testifying at your committee, and greetings to you, Chairman Hunt, and the rest of the committee. And thank you very much, Representative Connie Van Houten, for bringing this bill forward. I did send testimony, and if you look in your email, my email address is warner@330-608.com. It often goes to spam filters, so if you could fish it out of there, that'd be lovely. And see my thing. I have personal experience with this issue with clawbacks, and I was completely surprised. I've always had a very sound practice, and I do my submissions very carefully, making sure that I've honored all of the authorization requirements and such. However, I have two sides of this experience to tell you about, and one is, I think you're aware, my husband, who is a retired legislator from New Hampshire, Honorable
Member of the
Mike
Commerce
Gilman,
Committee.
and he, as you know, several of you are aware, and in fact, thank you very much. 3 years ago, he was stricken with a complete paralysis after a flu shot, and was in Boston hospitals for much of the year of 2018. I was down there with him much of that time. Thank you, people, for prayers and good wishes during that time. And he's still improving and getting better. And we learned a lot from the experience. It was very touching how many people showed care, and how we learned even more about our love for each other and our need for prayer. And we developed an intense respect for the medical profession. Even being part of it already myself, we just were amazed at the things people did. We also were grateful to have insurance coverage, and how it covered this entire episode, which was a lot of money, being in intensive care and such all over Boston. There were people at the insurance company who were very helpful advocates for us in the admissions process and such. They went overboard and did great things. Unfortunately, even as late as last year, which is like more than 2 years after the episodes of care, we were subject to clawbacks for that care. And many $1,000s, like $17,000 and $4,000, and all over the place, there were still clawbacks going on in that care. And certainly that was not the major part of what had been paid. Thank goodness they didn't pull back the big parts. But still, that kind of money is a huge amount of money for us, especially. I wasn't working much. I was following Mike to Boston, and because I was employment at the moment. At that time, he was couldn't work. So that was, over $20,000 that came upon us from these Boston hospitals. And still to this day, every month I spend a day on the phone with the insurance companies and the hospitals, and still trying to metal this out. This is from the patient side. From the provider side, as a doctor, I received clawbacks just before Mike went in the hospital. I was stricken with clawbacks that reached back 20 months. And there were so many errors in them, and it was just so impossible. They ended up taking these clawbacks from future payments of future patients. And there was no way to figure out where it was, how it happened. This was many thousands of dollars, because the insurance company had suddenly decided that they were going to use a discount for telemedicine, and they were going to apply this retroactively for patients who had received care. And it was very dramatic in my budget. My cash flow in my business went really badly at that point, all the same time that Mike's in the hospital. It was a very difficult time. I consulted with my billing people who submit these things for me. Nobody could figure it out. And the company that I use is a multinational company. It's not like they have no sophistication at all. And still to this day, those years that those were affected, I could not close the books on that account. I had to climb through, and I managed to finally figure out through this sweeping swirl of misaligned paperwork that was sent to me and unreferenced deductions from future payments, that I finally did get some of it, and I figured out where the mistakes were made. But by then, I couldn't go back to the insurance. This is now 3 years later, to be able to go back to the insurance companies and appeal those. It's gone. This is much money gone. So I just wanted to share with you the impact of a long, drawn-out clawback reach and how it hits both a consumer and a provider, and it's very dire. So I do support this bill, and I appreciate that it's being brought forward. I'll take any questions.
I don't see any, so thank you. It's nice to see you again. So Sean Hassel, I don't have you on my list, but I know you were mentioned and you're in your hands up, so I will let you speak here. But anyway, you just have to unmute yourself, Sean.
Hi there, can you hear me?
Yes, good.
Okay, thank you very much, Chairman Hunt, and thank you for having me. I had originally registered and was unable to make it, but then the system didn't allow me to change my status to want to testify, so they told me that if I just raised my hand, that maybe there would be that chance. So I appreciate you allowing me this chance, and thank you to representative members of Commerce Committee for all you do and for hearing this today. I'm calling to talk a bit about retroactive denials and how they impact, in this case, group practices. So individual practitioners are hit very hard by these, and I really do appreciate Representative Van Houten's and the other two people who testified in terms of their description of retroactive denials and how they really do hurt small businesses. And I just urge everybody to remember that during this time, there's been references to there being a mental health crisis today, right now, COVID having worsened that, and to please consider how these small business, and often if it's individual practitioners, sort of micro businesses, can be very, very hard hit in terms of impact on finances. I co-own a group psychotherapy, family therapy practice. We have offices in Manchester and Salem. It's 11 providers total in the two regions. And I thought I would just describe put some numbers on it, because at our practice we've actually tracked, how this has happened over time. So if you go back, this is only counting clawbacks or retroactive denials that are $250 or over. We have more frequent smaller ones, but in our experience, those are a bit more manageable to be able to track down. And if it's just say 2 sessions or 3 sessions and maybe only 3 or 5 months after services, we're pretty successful at getting those. But I'm talking sort of larger clawbacks, retroactive denials. So if we go back over the course of our history, we started in 2009, it's 28 total retroactive denials of that size or larger. So it's not an enormous amount each year, but the work involved is something that I'm wanting to emphasize today, and the impact financially can be quite large. So they have averaged those 28, $670 each. So some are smaller, $300, $400, $500. Others we've had retroactive denials amounting to $2,000, $3,000 a couple of times. The total of those 28 is $18,760 that we've been hit with at our group practice. And then following up on that with extensive outreach on our part, reaching out, trying to ascertain, was there another insurance that should have been primary, for example, or another responsible party, and trying to reach out to clients, many of whom are terminated. We've been able to get back $6,140. So that has left us with a net nearly $13,000 over a period of time. Most of that, by the way, more of those retroactive denials, I don't know why, they accelerated starting in 2016. So more of them have been since 2016. I want to speak a little bit to Representative Fargo. You had some questions about this. And yes, absolutely. Most often, the error has been on the insurance's part. Every once in a while, it's a shared responsibility with the client. We sometimes at our group have had clients that they fail to mention they have another insurance, and they don't know that that other insurance is the primary one. And so we verify benefits and we ascertain that there is indeed coverage. We start billing, and the error that the insurance makes is they pay it. And then they only later learn, maybe, and I have to say, it is particularly difficult when it goes beyond 6 months. When the services were rendered and finished up 6, 7, 8, 9 months, 12 months prior, it's not only a financial burden, the administrative burden is enormous. Each one of these retroactive denials, in my experience, to sort of troubleshoot and try to find what really went on. And then you're trying to reach, if you imagine, if you will, you're trying to reach a client who often has finished up services a year prior. And at the time, they thought it was all fine. It was all being paid because their insurance paid it. And now they're gone. And we have to reach out to them if it indeed is their responsibility, or to at least ascertain, is there another insurance if that's the issue. Sometimes they work with us, sometimes they don't, but often we don't succeed in getting those monies back. And I'm part of a group and we have some resources for that compared to an individual practitioner. And even for us, it's often quite overwhelming. And the time involved in each one of these retroactive denials, we're talking 2, 3, 4, I've spent up to 6 hours on one retroactive denial. So you can imagine an already not great reimbursement rate from insurance carriers then gets watered down. So if in this case, I'm often the one who chases them. So if I'm on, when I say 4, 5, 6 hours, it's calling the insurance company, being on hold, as everybody knows happens now. I've been on hold recently for insurance companies. It's been really bad the last month. I'm talking hour and a half on hold with Anthem Blue Cross, for example. And then it's trying to talk with insurance reps, trying to find out what exactly happened, how come they paid, and then what are they saying was the primary insurance if there was another insurance. And then it's sometimes we actually, another thing, Representative Fargo, to add to that, we have more than one time found the insurance is actually incorrect. There was not another insurance. Maybe the family started another policy but never paid for it, but somehow in the systems, it looks to them like there should have been another insurance that paid. I have to chase it down, talk with the family. The family says, no, we never even paid for that other policy. It takes, and then you're on the phone, and sometimes you have to elevate it to a supervisor. I mean, just the administrative burden alone is enormous. Enough so that it often feels like it's sort of geared for us to just give up and write it off. And we do. We often end up having to write off, each year we write off a few $1,000s because of this. I guess I just wanted to emphasize those pieces, and that this particular bill, the pieces that are helpful is that it would shorten it to 6 months as the default rather than 12. It is very clear to us that the insurance should have the internal resources. Heidi Page testified to that being the experience that, they have internal resources to be able to do this in far sooner than a year. And if you can keep in mind, if they can let us know that there's been an error on their part and they paid incorrectly and it's 4 months, often we're still with the client, or we can reach the client, we can apply more leverage. It may not be so difficult, and we're willing to do that work. But it's when it's many, many months later, and a lot of these retroactive denials come in the 6 to 12 month range. I agreed with Heidi Page's testimony that there is one part of this bill, it's the exception to E, that I feel should be eliminated altogether. If it goes beyond 6 months and they find that there should have been another insurance that was primary, really at this point, they have better resources. And we're not in a place, if anybody here, by the way, wonders, well, if the end, it's client responsibility, like you should have it set up. And indeed, in our informed consent, we have it set up that we reserve the right to say, report them to collections. But I just want to make sure all the representatives on this committee know that any mental health provider who's really thinking about it and attending ethics conferences and workshops knows that it is folly to report a client to collections, because it is not at all uncommon that they would do a spurious report of alleged misconduct to the Board of Mental Health just because they're furious that we're reporting them to collections. It also it flies in the face of our code of ethics to be able to do something like that when we know many of them are not even going to have the money to pay, say, a $1,200 bill that they thought was already covered a year after services ended. So it is just it's just not an option for us. So it leaves the provider, really the way it is right now with clawbacks, it leaves the provider holding all the responsibility, all the burden of the time involved, and often out the money for services rendered, at the time. So I guess I'll leave it at that, and I'm open to any questions that people might have.
Any questions on the committee? Seeing none, well, thank you very much for your testimony. We appreciate it.
Thank you.
So Marcy, I've already promoted you, so you're on.
Hi, I'm good afternoon, Chairman Hunt and committee members. I'm here to speak in support of 472, which you're considering in this committee meeting. I'm a licensed independent clinical social worker, and I have a small private practice in Newmarket. And I wanted to provide an example of how practices by insurance companies can have impact on small business. When I started this practice, it had been really important to me to support our military, and I volunteered for years with New Hampshire DBART, working with National Guard members and their families. And when I opened my practice as a solo practitioner, I became enrolled in the TRICARE insurance company in order to be able to provide treatment for veterans and active duty families. At the end of 2013, I received a letter from that insurance company that they'd conducted a retroactive audit of a client's account who I'd stopped seeing over a year and a half ago, demanding that I repay close to $1,000, despite the fact that I'd submitted claims correctly and had been given regular authorizations from them for treatment based on medical needs. And I sat in at the tail end of one of your committee hearings on prior authorizations. And in this particular case, they'd given prior authorizations for this client every 12 weeks for services. When I called in the New Hampshire Insurance Company at that time, I was told that there wasn't any, at the time, there was no law or rule that regulated how far back insurance companies could go. I know that since then, there have been a couple pieces of legislation that have taken it back to 18 months and then to 12 months. I still think that that's too long. As a small business owner, this represented a really significant payment to me. I sent a letter of appeal as it seemed really unfair that they'd certify eligibility every 12 weeks and then a year and a half after the client's case had closed, go back and tell me that I owed money from claims that were 3 years old based on the information that I'd submitted and the claims were correct. They told me the client wasn't eligible for service and they were going to begin recouping the money from future claims. Well, at that time, I stopped taking TRICARE clients. And finally, in 2015, I was contacted by their legal department and they offered me to file a good cause waiver around that, which hadn't been offered to me at the first time when I appealed it. They said there was no appeal. So I recognize that this legislation wouldn't apply to TRICARE, but at the time that this happened, I had multiple practitioners that I met with, and in our practice were required to consult 40 hours a year, a licensing period with peers, and we meet regularly. And just in the small group that I met with, there were many peers who had had similar circumstances with private insurers. It doesn't make sense to me that as a small business owner, I have to submit claims for many insurance companies within 6 months in order to be paid, and some even within 3 months. But companies can do a retroactive audit on a client and go back 12 months, requiring clinicians to pay money back when the error wasn't the error of the therapist. I know, as Sean mentioned, researching those claims is really difficult, particularly for a small business owner, solo practitioner. I'd recommend that the insurance companies be held to the same standards that they hold practitioners to in terms of being able to bill for services. So insurance companies, as Sean mentioned, have a huge staff who will regularly review claims. And so if we have to submit those claims or risk non-payment within 6 or 3 months, insurance companies should have to do the same thing. It's not uncommon for clients seeking treatment from my office, as other people have mentioned, to report a 3 or more month wait for the Community Mental Health Center for services. I know that other legislation's been passed has been filed to address the scarcity of mental health practitioners in the state. And I know that right now there are clients that I turn away every week. I have a small practice and I'm doing primarily telehealth because of the pandemic. But even still, I'm finding that there are many more people that need the support of mental health treatment at this point. This regulation, as it's written, discourages small business owners from coming into the field, and I really urge you to support this bill. And I want to thank you for your consideration and allowing me to speak on it.
Thank you very much. All right, so I do have some names, but I don't see them here listed. So I guess this is a little daring, but if you're an attendee and you were signed up to speak or wanted to speak, please raise your hand, and I'll promote you. Okay. Oh, here. Oh, Don Funstein. Okay, Don. And who are you representing today, Don? You have to unmute yourself. There you go.
I'm on audio.
Yes, you are.
Oh, okay.
You could turn your camera on too if you had capability.
Oh,
But I don't know, maybe I promoted you. But
I had a hard time.
okay, no problem. But so who are you representing here?
Here we go. Hi.
There he is. Okay.
For the record, my name is Don Funstein, and I work with Heidi Kroll. We represent AHIP here in New Hampshire. I vaguely remember this bill. I think it was back in January or February before the pandemic hit last session. And I know actually my peer, Paula Rogers, has actually been very involved in the issue as well. But my sense really is, are we going to continually rewrite the insurance code, the statutes, to deal with what is admittedly a very sympathetic but small component of the provider community, which last year, and from what I was able to hear this today, seems to still be the case. And really that's really the only point I wanted to share with the committee. And with that, I'd be happy to be quiet or answer any questions if someone is so inclined.
Okay, great. Representative Abel has a question if you're willing to take one. Go ahead, Representative Abel.
Yes, thank you for testifying. What are the main reasons insurance companies do clawbacks or requests to be reimbursed? For those of us who aren't in the business, it would be helpful to know what kinds of mistakes you find that cause this to happen. Are you able to give us some examples?
I'm sure the planners can do a better job, but probably the most obvious one to understand would simply be when there is no coverage. If there's no coverage on the date of service, then you shouldn't have a situation where you, by statute or otherwise, are encouraging someone to pay a bill that's not justly owed. With that, I guess I would say that alone would be a reason why you would be cautious before you expand what has been done in the recent past.
Yeah, I would say is I know that I often get when you have doing claims and stuff, a question to see whether it really should have been covered under workers' comp rather than your health insurance. That's the one I know of. But Representative Terry has a question.
Sir, were you on when we heard the testimony from Dr. Warner?
Unfortunately, I was not. I tried to get on, but for some reason it was not allowing me in.
She related to us an experience where she claims that clawbacks were.
Oh, excuse me, Representative. Do you mean the doctor or provider that was speaking immediately
Right.
prior?
Yes,
to me?
yes.
Yeah, I did hear that. She described a
I
scenario.
want you to hear what his question is first, Don.
Thank you, Mr. Chairman. She indicated that the clawbacks went back as far as 2 years. I think she mentioned something in the area of $17,000 to $20,000. She did not provide us with details, but was speaking about primarily about the time frame involved. Do you know why clawbacks should be going on 2 years to infinity?
I can't tell you. I'm aware of one similar to what she described, but I will tell you sometime, and I'm not suggesting this was the case, certainly with that provider, but oftentimes insurance fraud is difficult to discover and to be able to prove. So certainly that would be one example where you would have a long reach back. I mean, clearly, the story that the provider described, at some level, it starts to shock the consciousness, and in the absence of fraud or in the absence of some intentional misconduct that doesn't rise to that level, then you should have a bar against that long a lookout. And I think clearly, I mean, the law right now has been updated so that wouldn't be the case. The story she described, I think she said, would not be allowed to happen today.
Further question, Representative Terry, you muted yourself, so I guess, yeah.
Thank you for a follow-up. So you do believe that some sort of time frame is reasonable?
I think we've made one that may be reasonable.
So the answer is yes.
The current law is a year.
The answer is I personally think current law makes sense, but I mean, if you ask me if I think 3 years is appropriate, no.
Well, no, I didn't ask you.
Okay.
I asked you if you thought any time frame was reasonable. So thank you.
Okay, Representative Bartlett has a question.
Thanks very much. I have to say, Mr. Funstein, that you're not coming across very sympathetically to me. Yes, we changed it to 12 months after hearing many of these kinds of cases in the last couple of years. Because, I mean, do you think that it's reasonable for the insurance companies to require providers to bill within 3 months, but you think that 12 months is still a reasonable amount of time to claw back if you find something wrong?
Yes.
Okay.
Thank you.
All right. Okay, is there anyone else who would like to testify on this bill? Going once, going twice. Okay, so we'll end the public hearing on House Bill 472. And I am now officially, we're going to let everybody have a lunch break and get to stretch your legs. And we'll meet back here at 1:15. And just so you know, the computer is, we're going to continue to record. So you want to make sure you turn off your mic and cameras, and I guess is be the smart thing to do.
Mr. Chairman, I have a question.
Yes.
Would it be easier if we logged off and logged back in?
You could do that too.
Okay, thank you.
Okay, did I do that right, Pam? You still around, Pam?
I am still here. But the screen's jumping around, so I missed my mute button.
I can't see you. Where are you? Right.
It's hard to get that. Yeah, that was perfect.
Okay.
Point of view.
All right. So you're going to put up on the little note there that we're out to lunch, right?
I am. I'm closing a bunch of documents on my computer so I can find it quickly. So.
No, this is my desk and I have these papers here. So, okay.
It'll
Good.
be up in a sec.
All right, no problem. I will see you at 1:15.
I'll be back.
I'll be back.
Hey, Chairman Hunt.
Yes, Representative Weston, how are you?
I'm good, thank you. Just warmed up a little bit. I was cold.
Yeah.
How could you go over the blue sheets on the last couple bills when you have a chance?
I could have, but they were 4 pages long.
But they're supposed to be giving you a total of opposed and supports. If you could just give the totals, that would be great.
Okay, I could do that. So on 472, it was 223 in support, 8 opposed, 1 neutral.
Wait, could you do that again?
223 in the green.
Yep.
8 in the red, opposed.
Mm-hmm.
And then of course Tyler is neutral.
Oh yeah. All right. Thank you very much.
Yeah, I mean I could have gone through, but
I think even just mentioning that it's
I should have, but you know, I was more conscious of my time, but I will do that in the future, that when I don't list them, I'll give the numbers.
Thank you.
You're welcome.
Representative Hunt?
Yes.
Hi, Dawn.
Yes, Dawn.
I saw the caucus meeting for today.
Yes.
I have a little problem. I have a big school board meeting at 6:30 tonight.
All right, well, we hope to be quick.
Okay, I wasn't sure. I just wanted to let you know, just because of they're bringing up SB 20, and I want to be on there so that I can have representation in support of it, because I know they don't support it.
Really? Okay.
Yeah, the school board is not.
Why would they take a position?
Yeah, I always ask the question, if it's best for the kids, why wouldn't we do it?
Right.
And that's the first and foremost question in everything I do when it comes to my school board. And so I want to be there and I've got information that I can use to help back up everything. So I just wanted to let you know that if I scoot out, if we're not done, you know why.
Yep, no problem.
Okay, thank you.
No problem. Okay.
Love your helper, Anita.
I know he's my executive assistant.
Pushes paper for you.
Oh yeah, right off the desk.
John?
Yeah.
It was called to my attention that you didn't read the blue sheet on the
Yes,
last hearing.
it's Joyce already gave me a hard time.
Joyce is good at that. I like that about Joyce.
So, notwithstanding that half the people who were signed up to speak didn't speak, which
Well, we ran late though. That's hard when somebody
that,
has.
that was probably just as well.
Yeah.
But yes, there were 223 people who signed up in support.
223 in support. How many against?
8.
8. I'll have to get to them.
Right.
I have to say that the insurance, those who were testifying on behalf of the insurance companies didn't come across very sympathetically.
No. That wasn't the best.
Don Funstein, he and I go way back. He actually, how long to go back? This was literally back in 1980.
John, just to let you know, my screen says we're being recorded.
Yes, we are.
Just so that you know.
Oh, yeah, yes.
Okay.
But Don and I go back in 1980, and in which Arnie Arneson was on the committee, and she insisted that when we had the Indoor Smoking Act, she insisted to Lisa Frazier, who was the chair, that I chair the subcommittee of that bill. And Don represented businesses who were going to be affected by the Indoor Smoking Act. And so I've known each other a very long time. And so when he got on there, I go, oh, this is not going to be good. Because, he's filling in with Heidi. He's filling in for the lobbyist, so he's not totally up to speed. And
Right. And, Heidi did a good job. I don't necessarily agree with her, but she's always prepared.
yeah, no, she doesn't.
And it didn't feel like he was.
Don had no business weighing in at all. But it's okay. So like I say, Don and I go way back. So I have all the respect in the world for him. But and he's represents his clients well. But there are times when it comes to these health bills, I don't know how any lobbyist can say, "Oh yeah, sure, I can stand in for you," because the nuances and the elements of it is just overwhelming sometimes.
Yeah, it's really true.
Yeah, but even the wording.
And thank goodness we've got Tyler.
Oh yeah.
And we're very
I read some of these things 20 times and I think, what did it say?
And fortunately, Tyler's last one standing. He's still around. I mean, we've had a lot of changeover over there at the department.
It sure has.
Yeah.
So okay, all right. So looks like time to open up the hearing. And yes, this is one of those where I am sponsoring it for the department. So I would ask the department to introduce the bill, even though they would really love me to do it, but I just assume have them do it. So who's here from the department? Okay, there we go. All right. Good afternoon, Heather. You just have to unmute yourself.
Can you hear me now?
There you go. Perfect.
Yeah, I literally lost you just as you were about to try to get me. So
that happens sometimes.
So, my name is Heather Silverstein. I'm general counsel for the insurance department. This bill, the HB 519, is a technical bill, and it's trying to tidy up some of our insurance statutes. Marty Mobley, our legal coordinator, had submitted written testimony, I believe, yesterday to the committee. I can touch on some of the highlights if you'd like me to.
I think you should. I think you should go through.
Okay. So there's like 8 different things, and really it is truly technical. There were no surprises to industry. They're supportive of this bill. The first 2 relate to record retention, one inside the department and one for industry. Our record retention has been a really long time. It's been like a full 6 years. So we're decreasing that to a full 3 years. It's long overdue. Some agencies don't even have a record retention statute. So we're just trying to get up to speed with not having so much paper around and even electronic data. And so that's the first one. The second one deals with a underwriting file for companies and just making sure that they're keeping, it is required by law for them to keep a declination notice. So that's just clarifying that up in the statute. There's some confusion the way it was written. The other statute, the next one deals with mergers of companies. And this was based on an old NAIC, National Association of Insurance Commissioners model. So our statute was based on an old model that really made no sense as far as the timing goes, because we don't have control over when the merger is finalized, even if we approve it. So that date used to be based off that. It made no sense. So we're just putting in, after we have the hearing at the department, the commissioner has to decide within 30 days. So, and that's getting more up to speed with what other states in New England have done and have recognized that it's a timeline that makes no sense. So we're trying to make some sense there. There's another change in the deadline for holding companies. So right now the statute requires May 1. Again, the NAIC, the National Association of Insurance Commissioners, they don't even look at this information once the department has received it until like late fall. So it's helping our licensees and it's helping our staff as well, because they have a very busy filing season in the spring. and to kind of spread that out, these filings that have to be submitted by the companies. So moving that from May 1 to August 1 is really helpful for really everybody involved. We actually, it was particularly noticed last spring during the pandemic when there was companies that were having trouble. So that's what that's doing. There was a typo in the PBM law, the 402N5. It referred to it was supposed to refer to paragraph 1. Instead, it referred to a preceding 402N4. It made no sense. So again, we're fixing a typo in that statute. In the life settlement statute, 408D, we're adding solicits because that's actually what the definition within that same statute talks about for life insurance, life settlement producers. They solicit or negotiate. That's in the definitions. It's also in our typical, our general producer statute would talk about soliciting or negotiating. So we're tidying that up in that particular part of the statute, 408D3(5)(a). And then the last two, one is just getting our terms consistent with what's noted, what industry recognizes. And so like changing to life coverage and annuity contract so that we're not using terms that are not up to date in our statutes. And then the last one is 415 6N, dealing with the children's early intervention. There was supposed to be a reference to the ACA last year. I had discussions with Tyler about this. He just said it was inadvertently like left out. And so that's what we're doing. We're just including the reference that should have been there before. So, and that's everything. I'm happy to take any questions that you have.
Any questions from anybody? Okay. Nothing? Anybody else would like to? Okay, so this, we're doing 519. And what do I have for my sheets for 519? Okay. So is Marty not going to be around? Is she testifying? Is she around?
No, Marty's out today.
Okay. Okay. Snow day. Okay. All right. Is there anybody else? Anybody else who would like to testify? The attendees? Oh, we do have a hand up. Okay, great. Promote the panelists. Chris Clear? Oh, that's Chris. Why is he over in attendees? Okay. Who knows?
Lieutenant McClear has been coming in as an attendee, and I'm not sure why. I've been promoting him.
Oh, I see. You promoted it. Okay. And then
I have in the past. I will.
And then you have to rename him too. Okay. All right, there he is. Yeah, so you gotta now we gotta get it.
That was my question. I wasn't getting in.
Oh, you're echoing. Yeah, you got two devices on. Can't do that. Yeah, so whenever you do two devices, you want to always make sure you turn one of them sound off. But okay. All right. So is there anybody else who would like to testify on this bill? I guess not. So we'll close the public hearing on 519. Oh, it's too easy. Listen, I didn't think that one through. I gotta get how much time I give on that. I get way too much time. Okay. So just give you a little up to dates. So we are scheduling for next Monday and next Tuesday and Wednesday. And then Wednesday at 1:15, the hour, executing hour, or where I've scheduled like this, like tomorrow, we're having exec at 1:15. I was going to take on the bills we heard the first day. We can discuss those bills. And Christy, I'll talk to you, touch base with you so that you know what I'm thinking, and then you can get back and
Sure.
your people and my people, and we can see how we do. But I would emphasize to everyone, especially after today, any of these bills that are going to need amendments or really need time, we're just going to have to retain.
Yeah.
I mean, I just don't feel we can do justice to them without spending a little time and really working on them and making sure we get it right.
Well, I think we all acknowledge that we've had a couple of surprises. Things that we thought were going to be simple aren't going to be simple,
Right.
and we'll just have to work on them.
Yeah, and it just seems, makes sense that, we'll just put things off to the fall, and then we can, it'll mean we'll have a busier fall, I guess, but,
Well, depends on where we are in the fall. This
I can
pent-up
imagine
need to travel.
some people want to travel, right? We'll have to figure out how to schedule that in, but at least it's not an election year, so we'll be
Right.
time to work on it. But
I was just going to say, this last bill that Heather just presented, I am so glad I do not have to read through insurance law anymore. My gosh. That's dry as a bone, I have to say.
it's really it's really some of the oldest statutes too.
Yeah, I'm glad they're doing it. It needed to be done. We've had a number of bills that cleaned up a lot of old language. And I think that came from the previous insurance commissioner, wasn't it? The one who was there for a short time, John Ellis, was one of his
projects.
goals.
Yeah. Well, we did a lot of recodification going through the
Yeah.
department and
Yeah.
the same thing with banking, but I think that they're urged to do that through internal, what do we call that, internal, the inspector, whatever, general, or that they prod them to
Yeah.
get their statutes up to date and more compliance. But the insurance department has been as much as a problem because they have NIC really governing.
Well,
them.
NAIC can help them a lot, but it at least steer them in the right direction.
So,
But it's probably not things I would have taken on unless prodded.
Excuse me, Mr. Chairman, can I just do a little bit of business while we're in
Yes.
between? Representative McAleer? Is that the correct pronunciation? I hope it is.
Chris, you're on mute, so.
Yes, that's correct.
Okay, McAleer.
And the reason I had two on is that I wasn't getting my picture up there, so I put another one on. I thought it was my mistake.
Right. My question for you is, I've noticed that you come in as an attendee rather than using your personal link. And that's why you keep having that problem. You come in on the public link rather than your personal one. And I'm wondering if you're not getting it. I'm sending it to a private email address, not your legislative address.
Okay.
And
all right, you're right. I'm putting in my legislative address. I'll put in the other address from now on. Okay, I get it.
But you get just before an hour of the meeting, you get that thing from we call it what, HCS, or it is that.
Right.
And you just click on that one. That gets you in as who you are.
But I can send it to your legislative address if you prefer. It's all.
Would you please do that?
I will change the address, and then that it should be much smoother for you every day.
Thank you.
And Chris, you should tell the House Clerk's office that you prefer to have your personal address used, because it needs to be consistent.
I've asked, no, I prefer not to have my personal address. I prefer to have my legislature.
Then maybe you need to tell them. Is that what's listed on your when you go into the New Hampshire General Court and you pull up House of Representatives and members, what does it show for your address on there?
I'll have to go check that out.
Okay.
And just so everybody knows, the original address that I used for all of your accounts was what was posted on the website. But then I know some people changed that address, and I didn't get change of address notices. So that could be the explanation that Representative McAleer at one point had his personal address and then asked it to be changed, but I didn't recheck everybody's addresses.
Right.
So
This is the first time that that's happened. Every other time I've been able to get up there. Thank you.
Okay. Well, It'll be your legislative address from this day forward. So we'll stick with that.
Okay.
Thank you.
Yeah, I never got a legislative address. I just figured one more email address was going to be a nightmare for me. You know, but as it is, I have a Gmail account which I don't tell anybody except if I have problems with my Prodigy account. How about you, John? How many emails do you have? 4.
4 possible.
Yeah, possible.
But I only use Comcast for my regular and my Ledge Mail for this stuff. I've already had a good conversation about which mail I can use to get to what emails, because in order for me to do this, it comes in on my Ledge Mail. I forward it to my regular email. Then I go up to Comcast and put it in one of my file folders in Xfinity, and that I can use on my laptop.
Right.
So
Okay.
this is not easy for me.
That seems very labor intensive. But
It is.
also, so now of course I'm a Mac user and I haven't really done PC on mail, but I assume you pretty much all the features are the same. So one of the things that I've been doing, so I thought I'd pass this along to everybody, then when you get people's presentation, when their testimony and stuff, what happens is when they register to sign up, they at the same time can upload their speech. When that speech gets sent, it immediately gets emailed to your email address. So what I have been doing, and I'm just passing it on, is that I have color flags on my Mac, and I assume PC has color flags or something like that. So now I've just chose a color, and so I flag all those so that if I ever need to go back and look for testimonies, it would all be in one sort rather than trying to stick it in a folder. I just use that flag feature. So is there one of you guys a PC user? Do PCs have the flag?
Yeah, I print it out and put it in my trusty 4-inch binder.
Well, that's
that's old school.
That I ain't doing. Filing. I'm not a filer. My computer is my file box. That's, when I tell people, I said, you're better off sending me an invoice or something, that just email it to me and I can find it faster by searching on my mailbox than I can printing it out and filing it or whatever I may not doing with it. But so, okay. So the next bill is
145.
145 and Representative McBath.
We have.
Oh, great. Representative McBath, another former member of the committee.
Is Representative Weston still with us?
Yes, she's there. She's just got her camera off.
Yeah, I'm here.
I'm wearing a ski tie
Right.
today, just in honor of all the snow that we got.
Downhill ski, yeah.
I figured you would get a kick out of this one.
I'm going on Thursday.
There you go.
I'm
Thursday.
so jealous.
We'll be out.
You going up to Cannon?
Yeah. It's going to be pretty nice.
I'm so jealous.
So, Chris, you have your hand up. Did you want to?
Yeah, you were discussing organizational things, and my question is, with your legislative email, can you create folders in that email? Because I don't really know how to do that. Because so all my commerce stuff will go into a folder, because that legislative email is 90% junk, and it just adds up so quickly. If I don't catch those,
you're getting junk in your legislative email.
no, it's just so. Okay, are you being sarcastic?
No, I'm saying although I'm so glad I don't do that way, but I didn't realize they would get junk by that.
I was just looking for something that would a folder that I could.
Are you a Mac?
It would automatically go into a folder.
Yeah. Are you a Mac person or a PC person? What do you have? For
It's a piece, I'm a PC person.
PC?
Not Windows, but Firefox.
Right.
You
Well,
blocking the junk?
my
Huh?
You can block the junk so that somebody doesn't keep sending it.
No, I just find most of the content is junk. So
You can block the user.
Oh, well, that's another story.
You know, it goes, it says,
I don't
it
know
says
about
bulk.
Nita, I had to turn my junk off because my constituents would show up in the junk file. I mean, I was having, I don't know, it was, I got rid of it because, I mean, spam folder.
I get email from Ethiopian princes telling me I've won the lottery.
Oh, I haven't gotten those.
Right, but is the answer yes, that I can actually create a folder in legislative email?
Oh, yes.
Yeah.
I have many folders.
On your computer, on your mail program. What mail software program are you using to read your mail with?
I don't know.
It's Microsoft Mail.
Microsoft Mail.
Yeah.
Or Outlook? Wasn't it called Outlook?
Yeah,
lost it. But
I use Gmail. I don't know what
Gmail. You're logging into their webpage, and you know that what you want to be doing. I mean, maybe you're not doing, is that you want to use Outlook or use a mail program. In other words, Apple is called First Class Mail, but then Microsoft had an Outlook program for the Macintosh. But Outlook am I right? Outlook is the program for Microsoft Office. I mean, do you have Microsoft Office, Chris?
Yes, that's what we come in.
I don't think so.
Yeah. I know that they used to charge extra for Outlook. I know it was more expensive to get that, but that's the mail program in which, you can put in things in folders and organize your different emails addresses.
So my legislative email, I have to go to Outlook or someplace like that.
Right. Well, in other words, like I'm using my Apple Mail, so on it I have all my different email addresses, and then I have and then below it is folders, and you can drag things and put them in folders, or you can, I do flags, because flags are kind of nifty. You just hit the color and it pops all my.
I don't know. I just I don't have folders anywhere but in my social media.
You got to use a mail program. You need a mail program. So if you're using a PC based machine, do you use Word, Microsoft Word, and Excel?
I don't use Excel. I use Word.
Word.
As long as it's English, I use it.
Well, no, they got translators too, Well, Microsoft Word, Outlook works with Word, so you can do something like mail merge, and with Outlook you'll have everybody in there, your mail, and you can send out and print labels for Christmas cards, and you can send out formal letters with their name on with Word. It mail merges. But
I'll figure it out.
You can ask
right now, I just try to catch everything every day, and then but if I go away for 3 or 4 days, and I come back with 400 emails in legislative mail, and I just edit them and cancel them all.
Chris, you can ask the legislative tech support office. They're really helpful.
Yeah, I think I'm going to make a phone call.
Yeah.
I mean, I know what folders are, and I have literally 80 folders in my browser,
right.
my Firefox browser.
That's on your desktop.
It's on my desktop. Yep.
So you have to drag it from, and then drop it in, drag and drop. But okay,
Anita, don't forget to follow up with that letter you got. You make millions.
Oh, I already did. We're good. We're going to retire.
All right, good.
We got it. Thank you, Chris.
I'd probably have Representative Macbeth's phone number, right? Make sure she knows to get on. Let's see. She's still not on, right?
Has she been on?
No, I haven't seen her.
No, I just checked attendees.
Yeah.
We are still 5 minutes early.
Yeah, I see that. So Hi, we're ready for you. Oh, ouch. Okay. Um, I'm sure I'll find someone who will introduce it for you. No problem. I'm glad I called, so we didn't wait for you. So, okay, no problem. Right, talk to you later. Bye. Yes, I'm in her phone too. So, she is judiciary, I guess, is executing right now, so she's not going to be able to do it. So, Chrissy, she was asking if you would be mind introducing, or anybody who we've had, for those the new members, we've had this PANS somewhat issue around from the past, but anybody feel well informed enough to want to talk about it? Don't all jump at once.
Sure. I'm glad to do it.
Okay, great. So we can wait 3 minutes, I guess, and see if anybody else. So
You're a little bit early, or are you going to start?
It's a little early.
I guess we can wait. I don't know. God, I can't believe
I
it.
don't care. I'm here.
Screwed up with that department bill. Should have only did 15 minutes for the department bill, but you know, I don't know what I was thinking when I did that. But, and now I also have that Tyler will speak, and then Heidi will speak. Okay. And I see Heidi is here, and I assume Tyler I never turned off, so he.
We ever let him leave when
No,
there's
I haven't.
insurance
No,
bills?
No, he's not allowed to.
I don't know what we do without Tyler.
All right. Well, why don't we just get going here? So why don't you do the best you can, Christy?
Okay. For the record, I'm Representative Christy Bartlett. I represent Merrimack County District 19, which is located in the city of Concord. I'm not on this bill, but I have worked on this issue for the last couple of terms. PANDAS, which is the acronym for Pediatric Autoimmune Neuropsychiatric Disorders. Sorry, that's why we call it PANDAS. Is a very complicated, difficult to diagnose condition, and seems to affect young teenagers right up through adulthood. And we had lots and lots of testimony by various family members that have had to deal with this over a period of years with their children. So this bill, we actually did implement a bill, I think it was 2 years ago, that provides some limited coverage for the PANDAS syndrome. And this bill requires the insurance commissioner to review the implementation of the requirement because, and report back to legislature, because there was a sunset clause in there. And now I don't remember how many years it was for. I think it was for 2 years, but it might have been 3 years. Do you recall, Connie or Joyce?
I think 2.
Yeah, I think so too. So we're coming up onto that 2-year limit. And what we want to know is whether the insurance companies have been paying for, well, to see what the impact has been for covering treatment for this rare and very, very expensive treatment. Is that enough?
That's perfect.
Okay.
So, so Tyler, why don't you go ahead and tell us what's been going on in the department over this issue?
Sure. So Tyler Brennan with the Insurance Department, and thanks for the nice comments. I'm happy to be as helpful as I can. So yes, this legislation passed a couple of years ago. It's a little unusual for an insurance requirement, though. Just want to say a little about that. It's typically when you get your health insurance, it covers a range of services. If an insurer decided they were not going to cover services for a particular disease state, say diabetes or diabetics, that would most likely be considered discriminatory and it would be prohibited. This one actually does say insurers will cover this particular treatment condition, but the reason for that is because there's some disagreement in the medical community about the treatment and the condition. So it's sort of a legislative step forward or step backwards, depending on how you're looking at it, in the way that it's specifying coverage for a particular disease condition that typically would be considered discriminatory if there was a lot more clarity around the disease condition. That said, New Hampshire has access to our all-payer claims database, our New Hampshire CHIS, which is a detailed but anonymous set of data that would normally allow the insurance department to and identify, at least anonymously, the number of people who had a particular diagnosis, a particular condition, and then the costs and healthcare services associated with that condition. This one's a little bit less straightforward because the diagnosis code that would be used is D89.89, and it's described as other specified disorders involving the immune mechanism not elsewhere classified. So this diagnosis code might be used for other conditions as well. So the department would be hampered in the way that we would go to those claims data to be able to identify the people and the treatment and utilization. So in order to satisfy the requirements that are in this legislation, we'd actually have to specify what we expect the carriers to do in the way they're going to track the patients and to report to the department. There's not a lot of substance in the legislation about what we would be looking for, except perhaps the number of patients and maybe something about the costs and treatment. But we would have to tell the carriers to do this prospectively, I think. Most of them, based on the feedback I've gotten so far, haven't established kind of an effective tracking mechanism because of this wishy-washiness with the diagnosis code. You might be able to look at a couple of other services that are likely to be provided to these particular patients, but however you approach it, you're going to end up, I think, with a lot of false positives, so kind of a wider net than what you really want. Ironically, perhaps one of the ways the carriers could identify these patients is if there was some sort of prior authorization for treatment. But I won't, we've discussed prior authorization.
Beat that horse.
Don't do that.
So I think maybe one of the things that could be considered if the legislation, if there's interest in passing the legislation, is moving the due date out from this November 1st, 2021, to something further in the future so that we could tell the carriers when the legislation becomes effective, this is the kind of information we're going to look for from you, figure out how to track it, and we could obviously have some back and forth as to whether or not it's going to be an effective way to do it. But yeah, that would be essentially the only guidance or suggestion I think I would provide beyond what we could do internally. Happy to take any questions you have, and thank you.
Okay, anybody have any questions? Yes, Representative Herbert.
I don't know if I understood everything that was just said, but I got the impression that Tyler, the insurance department, probably wouldn't mind looking into the matter and getting some clarity, and then we can consider legislation. I don't know. I heard a cautionary tone to his remarks in that there is this problem in regard to diagnosis, I think, and we need more information there. Otherwise, they're kind of don't know what what kind of data they want to collect until that's cleared up. So this sounds to me like something we should retain, but retain or study, whatever you want to use, and ask the insurance department to get some clarity for us.
could be a would you believe, or you want to
I can
respond to
believe
that, Tyler?
Yeah, would you believe, but yeah.
Okay, you don't want to respond to that, Tyler. Okay. So Representative Fargo, you have a question. You're muted. You.
Okay, sorry. I was just having a little problem. Thank you, Mr. Chairman. Tyler, do you remember from the original bill when we passed it to allow for coverage for this particular issue, what the date was that it would expire? Because I have some concerns that if we push out the date for the reporting, we may stop covering this. And I remember us putting the bill through, but I don't remember when that coverage was going to stop. Was it 2025?
I think it's 2024.
Could you check that for us?
So Representative Macbeth is here, so we'll let her pick it up. Thank you, Tyler. So Becky, you're on.
Thank you. I'm so sorry. Hello to my colleagues, and I really apologize for being late. We had on Judiciary, we had an unnoticed executive session. So I was in that, but it was a friendly one. There were no objections. This bill, this exact language, I believe, passed last year through the House Commerce Committee 20-0. And it's a follow-up to a bill that we had passed, the House, both chambers passed, and the governor actually signed it in July of 2019. So the bill in 2019 required New Hampshire licensed health insurance to cover the PANDAS collection of PANDAS illnesses. And it sunsetted in 5 years. So that would be in 2024, I think, 2023. John, you remember this stuff better than me, but anyway, this bill, I'm sorry.
I can give you the date if you want. I just looked it up.
Great.
Okay.
Great.
It's
Thank you.
July 1st, 2024.
2024. So because of the 5-year sunset, this was to collect the data on the bill to determine whether or not, citizens are making claims, whether they're being covered, whether or not this was a beneficial bill or a beneficial policy to cover that. In 2024, we'd need to have the information from the insurance department as to what claims had been filed and how it had gone. So it's really, it's just a collection of data from the health insurance. But again, we need to request the New Hampshire Department of Health Insurance to collect and analyze and report back to us prior to that sunset. So I think that the bill says that it would be reported back, into 2023 or something like that. But I just heard a little bit of Tyler's. The bill was not controversial, and if something's different and it needs to be changed, I'd certainly leave that up to the committee. Thank you.
Okay. So we got some hands up now. Let's. I have to see who put their hand up first. Okay, Representative Bartlett. Sorry, Chris.
There we go.
Chris.
Okay, so, sorry.
Nothing. Go ahead.
Oh, so Mr. Brennan, so what you are, I'm trying to clarify here. So you're saying that the insurance companies haven't been able to code this properly to be able to determine, at this point anyway, determine whether this treatment that the bill covered is actually, 1, being utilized and 2, being effective. Is that correct?
Not quite. So the diagnosis gets coded by the healthcare provider and then submitted on the claim. And typically the diagnosis used to justify the services being provided. The problem is the diagnosis for this condition, or at least the one that is coded when patients have this condition, is a bit of an all other diagnosis code. So it could be that diagnosis code could be used by a healthcare provider for something else. So, I mean, company or the insurance department using claims data would identify potentially patients that are not actually diagnosed with PANDAS the way it's described in the legislation.
So can I follow up?
Further question, Ingmar?
Thank you. So if the codes aren't giving the insurance companies enough specific information with this bill, what would this bill do for us? What would we gain from this bill?
Well, you would still require, the legislation would require the insurance department to produce a report, which means we would make our best effort to work with the carriers to be able to identify these patients and be able to report on them. And it sounds like, based on your testimony, that you're looking for really high level information, just the number of patients, whether or not coverage was provided. So I think that's good news. I think if you wanted a lot of detail about the services they receive and the costs, then it starts to get a little bit more challenging. But regardless, the carriers would have to develop a system for tracking those patients, which was my concern with the reporting due date. If we are planning to produce a report this November, that's not going to allow enough time to effectively work with the carriers to figure out how we're going to track these patients and then produce a report of value to you.
Further question?
Thank you. So if this sunsets July 1st of 2024, which is approximately 3.5 years, 2.5 years, how are we going to meet the requirements of the bill and still be able to provide the specialized treatment for this rare condition?
Well, the good news is we're still only in 2021. So if you move the reporting due date out a year, so November of 2022, you'd have it in time before the session to make it effective and continue the coverage.
So we go back to Representative Macbeth, so you can, Becky, you want to finish your thoughts here?
Thank you, Mr. Chairman. One of the reasons why the early reporting was requested in the bill is because one of the problems that we've seen across the country and here in New Hampshire is that there are different codes for the treatment of this kind of myriad of illnesses or chronic disease. So having the New Hampshire Department of Insurance kind of watching that, and then again, they're not the education piece, but the PANDAS network or other providers, it's sharing information. Well, this is the code that you use for this. So it really is in order to figure out whether or not PANDAS is being accessed, for people's insurance coverage, we need that kind of incremental or stepped up, not a complete analysis every year, but some type of report back is like, this is how it's being coded for this provider or this insurance company. I know that Paula Rogers testified last year, Anthem Blue Cross Blue Shield, they'd already been covering PANDAS. So this wasn't a new requirement for them, but one of the reasons they had a hard time telling us how many cases they had is because of the coding issue. So I agree with Tyler that it is, we're looking for kind of a high level in the beginning and some information so that then the stakeholders can figure out what they want to do with that. And then, it'll be another report, the following year. Thank you. Thank you, Mr. Chairman.
Thank you, Mom. Representative Herbert. You'll get it one of these times.
All right, one of these days. Thank you, Chairman Hunt. So I was under the impression from earlier remarks that this bill was going to sunset in like a year, but that was not the case, and so that's when I got it off into retention and that kind of stuff. But I don't understand now that what I'm hearing, I don't understand why a bill is necessary in order to have the insurance department do that research, because the bill is not going to sunset for over 2 years or 3 years maybe. So it's always going to be in effect. Why are we passing legislation to get a study done? I don't quite understand that.
You want to answer that, Rebecca? Becky?
I'll defer to you, Mr. Chairman. Thank you.
Oh, that's good.
I mean, well, because I would assume that we have limited resources in our Department of Insurance, and they're not constantly auditing every coded condition. I mean, and so why would they be reporting back to us? I mean, we need the information reported back at a certain time. I mean, I don't know that we have, they do that. We can ask Tyler, but I don't think we'll get this information unless we ask for it.
Well,
And certainly we won't get it so that we can try to help people be covered in this period of 2.5 years before it sunsets.
Do you want to tackle that, Tyler?
Sure. Yeah, no, it's, I think it's a good question because we do produce analyses that are hopefully insightful about the facts that are related to legislation. And we do that within existing resources. This is a bit different because we'd have to create a new reporting requirement for the carriers. And I think for us to do that, it would be very helpful to have clear legislative direction that it's important or it's felt important by the legislature for the insurance department to expend resources, well, both at the department and at the carriers to produce the information.
Yeah, I guess I'm trying to jog my memory. Because I feel like we had the bill twice. And the first time we didn't do anything. The second time we came back and we had the department to try to tell us whether there's a problem, tell us what's out there. How do we track it? Because it was clear that different insurance companies were treating it in a different fashion in terms of the diagnosis codes, but just each one had their own way of looking at it. And my memory, the original bill was to mandate some medication that was controversial to begin with. So then, so I guess that my best guess, the reason why we did what we did was for you, the department, to come back and say, well, here's what we know about whatever world of pandas that exists, and whether there's coverages or whether there's issues that still can be up there. But here's what we know so far. Is that possible? Well,
I don't recall that specific dialogue on it, but it may have taken place with somebody else from the department.
Okay, all right. Representative Macbeth, and then I'm Representative Bartlett.
So thank you for jogging my memory too. Yes, the original bill, which did there was an issue about the plasma. There was expensive plasma exchange.
Right,
so
right.
It's a treatment. What was happening is that the original bill is passed and that Governor Sununu signed on his desk. He supported it. It required that insurance carriers, health in New Hampshire, that they offer that be one of the tools that they allow providers to have. I think that was one of the controversies, that hadn't been authorized by all insurance carriers as a treatment for this PANDAS condition. And so I think that was one of the reasons we wanted this tracked, is how many medical providers are recommending that for their patients, and how many people are actually getting it covered. I think that was part of it, so that we could, and then the code issue. There were several confusing things about it, but thank you.
Great. Representative Bartlett. Uh-oh, she froze.
It certainly was a few years of very passionate testimony from the families. But I think that Representative Macbeth has got this right, is that some of the carriers were willing to do a less expensive treatment, but they weren't willing to do the really expensive treatment. And that caused the controversy. But the compromise on the bill that passed was that we would have a review of whether this expensive treatment was effective over time. So my question to Tyler is, if we put this out to say November of 2022, is that more doable, do you think?
Yeah, that's what I was initially thinking, although the level of detail that you may actually be interested in would make the reporting requirement, I think, a little more complex, assuming you are looking for whether or not, I guess, the more expensive treatment is being provided, that level of detail.
You don't think that would show in the insurance carriers, because it's got to be a huge line item. We were talking $750,000 to $1 million at the time. That's going to show up in somebody's report.
Yeah,
even if it's miscellaneous.
Sure.
I don't know. I thought it was just a handful of cases.
Yeah, it wasn't just a handful of cases, but it was so expensive. And the alternative was in one family, the child landed up in jail because of the various kinds of symptoms.
Well, okay. So I do have Heidi Kroll. So Heidi, are you out there? So I can, yeah, all right. Then it's Heidi. You're gonna get the last word here, Heidi. There she is.
All right.
Hope you enjoyed your time at Health and Human Services and
Yes, I was over in Senate Energy.
Energy. Okay.
I'm back. Happy to be with you. For the record, my name is Heidi Kroll. I work at Gallagher, Callahan, and Gartrell, and I represent AHIP, which is America's Health Insurance Plans, the trade association for the health insurance carriers. So I've been following the discussion here, and so here's what I understand the challenge to be, and I'll try to be clear about this. Happy to try to answer questions, but from what I understand, there is not a specific diagnosis code for PANDAS. So there is a lack of an ICD-10 code or a specific diagnosis from the American Academy of Pediatrics. So that's part of the challenge, is that we don't have a diagnosis code where we can clearly identify who the PANDAS patients are. We know from the past work on this bill that there were a variety of treatments. I think OCD, if I remember correctly, kind of OCD symptoms were part of this disease, I guess we'd call it. And so, you know, that was part of treatment sometimes. I think the expensive treatment that was being referred to was the IVIG. The problem with that is that the use of IVIG is used for other patients as well. It's used for different rheumatoid diseases, rheumatic diseases. So again, depending on how you cast this net, you are going to be capturing people who are not PANDAS patients. So, you know, we appreciate the opportunity potentially to get the date pushed out, but I'm not sure that that's going to help us solve the problem, since it's not really the carriers aren't really standing in the way of identifying who these people are. It's the lack of diagnosis codes and the lack of a very specific treatment that's received only by these patients. The other thing I guess I'd mention is, you know, I'm wondering if there potentially is another way to get at this. Obviously, we have the mandate, the coverage mandate, like all coverage mandates. Presumably, the carriers are covering that. And I'm wondering if there's have been any complaints, consumer complaints registered with the New Hampshire Insurance Department over lack of coverage or concern, because I think we did hear in prior years testimony on this that but the people had reached out to the insurance department. And so, you know, that would be at least one place to look to see if they've received any complaints since the passage of the bill. So I don't really have a good answer for the solution here. I'm only here to share the problem with you, which is just the kind of challenges that this bill poses in terms of trying to track folks to get you the information that you're interested in.
Okay. Any questions from Heidi? Yes, Joyce. Excuse me, Representative Weston.
Yes, thank you, Heidi, for your testimony. How does one get an ICD-10 code?
I don't know. I can try to find out for you, but I'm not sure. But that's what I was told, that there's a lack of an ICD-10 code or a specific diagnosis from the American Academy of Pediatrics,
Right.
Which makes tracking pandas difficult, if not impossible.
Exactly.
Seems it needs to be rectified there.
Well, because there's so because it has so many different elements to it in terms of the symptoms, it usually gets whatever it's being addressed is usually being addressed for those other symptoms rather than defining it as PANS.
Right. As Tyler mentioned, there's a non-specific code called a disorder involving the immune mechanism unspecified.
Right.
But of course, there are other people who don't have pandas who are also coded that way.
Right. Right. Exactly. Because it's a catch-all.
Yeah, exactly.
Right. Let's see. I have a couple hands up now. So Representative Abramson.
Thank you, Mr. Chair, and thank you for taking my question. I do have a question. Do you know what the cost of the intravenous immune globulin treatment is? Is it going to vary from patient to patient? How often I need
I
it?
would have to get back to you. I'm happy to look into that and get back to you. I don't want to speak out of hand. I do, as Representative Bartlett mentioned, I do recall that some of these treatments were pretty expensive, but I'm not sure that that's always the case for every patient. So I can look into that and get back to you.
So there's not a real protocol in terms of the step system on how to deal with this because it really is symptom driven. You know, what are the symptoms that the person's having, and that's what they're end up trying to cure. But Representative Fargo.
Yes, can everybody hear me this time?
Yes, we can.
Thank you, Mr. Chairman. Is there a potential to perhaps see if there was an uptick in that particular unidentified kind of blanket code after we passed the legislation that would indicate that there was an abundance of pandas cases that would be affecting it? Because I think the original reason we wanted this reporting was to determine whether we wanted to continue to provide the coverage. And so I'm wondering, Tyler, if you could see whether there was any kind of a change after we put that legislation through that would indicate some factor for us.
The short answer is yes. I mean, to the extent you're just looking for a rate billed by that diagnosis code. So you could, yeah, and we could do that with existing resources, I think. So the existing claims database the department has access to and consulting resources.
So Representative Macbeth, what I'm thinking now is that maybe retaining this bill is the right idea, but that we would want from the insurance department, Tyler, is that by come next fall, you guys can give us a preliminary report or tell us where you guys are at with it. What do you know? What do we learn? You know, just give us some tidbits so that, you know, we can then come September, October, when we take it to review the bill again, we can at least see where we're at right at that time. Is that possible?
Yes, definitely.
Okay, you okay with that, Maggie?
Yes, thank you. Thank you, Mr. Chairman. I would be okay with that. Thank you very much. Thank you, Tyler.
All right. I think that might be the right solution for now. All right. And I have no one else who wants to speak on this bill.
Jane Boley.
Oh, yes, Jane. Yes. Go ahead, Jane. Sorry.
All right. This is my first, year on this committee. So I really haven't heard, much about, many of these issues, but it sounds like it's a pretty invasive procedure if it's that costly. Because it sounds like maybe there are many doctors that don't approve of this treatment, or could somebody sort of explain why it's so expensive?
Well, again, was the medication that was
all right,
was very expensive, but again, that medication was more the symptom, that particular symptom, that it was manifesting itself, rather than that, you know, you're diagnosed to having PANS, and this is what we're going to give you.
All right.
So it's
Okay.
it's a conundrum. Did I get that right, Christy?
Yeah, thanks.
Right. I think what, somebody coming into this cold doesn't have a clue what the symptom was. And it's somebody, what they have found out is that it's from children that have had strep throat. And it has it's a neurological disease. It affects the brain, but it comes out in many different ways. And the treatments are complicated. And this particular treatment is very expensive, but it has shown, according to many of those that testified that were able to afford it, that there was some efficacy on it. So that's why we worked so hard to get it. One lady lost her house because she spent all of her money for treatment. Another one had the money. It was a doctor's child, and it goes on for years. I mean, it took, I think in one case, it took 6 or 7 years to even diagnose it.
Yeah.
But many different manifestations of the disease, and it's really insidious. So doctors are grasping.
All right. So Representative Macbeth, I'll let you have the last word here.
So I just wanted to agree with everything that was said. The immunoglobulin treatment, it's very similar to the treatment they give you if you are being treated for rabies. And they have to take plasma from healthy people and they mix it with, whatever they're doing to fight the rabies. And so it is a patient specific. It's based on weight and how much, what your exposure is. So it's not really that strange of a treatment. It's expensive. I think that a rabies shot, regimen can be about $10,000 if you do not have insurance. So, but that's what this immunoglobulin is. It's taking stuff, blood product out of somebody else, and it's injecting it into, that is such a unscientific explanation, but I just wanted you to understand it's not that weird of a concept. It's something that we all might, know somebody that's had that type of treatment.
Fair enough. Okay, so I have Jennifer Jones, who's a member of the public, who's in support of the bill. Eric Rathman, and is also a member of the public and supports the bill. And I have then Sabrina Dunlap from Anthem, which is neutral on this legislation. And with that, we'll close the public hearing on House Bill 201 and 218. So we're going to go right into another old favorite. It's nice seeing you, Becky. Take care. All right, Representative Weston. Are you ready to revisit this one?
And this is an old favorite. You're absolutely right. It's been going on for about 10 years now.
I think I remember this going back when I first got on the committee. This issue, it's always been around. But
well, you're the one who would know that.
Right.
So, Chairman Hunt, Commerce Committee, thank you for the opportunity to introduce this bill. For the record, my name's Joyce Weston. I represent Grafton 8, which is the towns of Hebron, Holderness, and Plymouth. This deal deals with the problem of surprise billing, a balance bill after an ambulance ride. And a study from Brigham and Women's Hospital in Boston found that 71% of ambulance rides are likely to generate a surprise bill, with an average cost to the patient of $450. Ambulances have the highest out-of-network billing rate of any medical specialty. And when you're in need of an ambulance, you don't necessarily have the capacity to choose whether the ambulance is in or out of your network, and you probably have no choice as to whether to accept the ride at all. But you could be hit with a substantial bill, which creates additional hardship, both financially and emotionally, on top of the injury or illness. This bill bans this practice. In New Hampshire, local governments, supported by our property taxes, provide the majority of ambulance rides via the fire departments or standalone rescue squads. The cost is a huge burden to our small towns. I live in one of them, and our property tax rate hovers around just under $30 on 1,000. It's a cost. This is because the reimbursement rates offered by in-contract negotiations with insurance providers are woefully inadequate. This bill requires the insurance carriers to offer a commercially reasonable payment, and I'm sure we'll hear from Tyler Brennan about that wording. If there's a dispute, the commissioner of the New Hampshire Insurance Department will determine if the fee is appropriate. One thing we added to this bill, though, is that they have to consider the higher costs in rural communities. Reimbursement payments aside, there's a national move against balanced billing. In December 2020, Congress passed legislation to ban, I have to turn off my phone, excuse me, to ban all surprise medical bills, with one notable exception, and that's ground ambulances. In response to this omission, several states are trying to fill the gap through legislation. Maryland and Colorado have added ambulances to their surprise billing ban. The Department of Insurance in Texas has recommended it. New York and Illinois have similar bills to the one that we have here. In Colorado, insurers are now required to pay ambulances 325% of the Medicare rate. Medicare does ban balance billing, but it has absurdly low reimbursement rates. In Plymouth, it's around 13.2% of the cost. They do have a program going on right now, though, which is reviewing its payment rates under pressure from Congress. But this process is going to take years. I heard from one fire chief that it's going to be about 5 years before we actually get any change. In the process of working on this bill, I talked to a lot of interested parties, and I'm very much aware that the ambulance services are underfunded and they're worried about a loss of revenue. I'm sure we'll hear testimony on that today, but I also think it's important for you to know that this year, because of the difficulty of our session, we wanted to keep this a simple bill. We didn't try to resolve all the problems of how to get reasonable insurance reimbursement. So we decided to really focus on balanced billing. And then I would like to work with some of the people I've been talking with to come up with a more comprehensive bill to deal with the other issues in 2022. So for now, this is about balanced billing, and I'm happy to take some questions.
Any questions from the committee? Okay, seeing none. Chair will call on Tyler Brennan, and Tyler, so why don't you give us the department's perspective?
Sure.
Ongoing.
So Tyler Brennan from the New Hampshire Insurance Department, and we don't have a position on the bill, but we would be very supportive of a legislative solution to ambulance balance billing. This is seen by the department as one of our bigger consumer concerns. We do receive complaints from consumers who have been balance billed by out-of-network ambulance companies, and it's a very difficult sort of challenge to solve. So we'd be very supportive of a legislative solution. The earlier legislation that passed in 2018 dealing with balance billing was specific to 4 different hospital-based professional providers: anesthesiologists, radiologists, pathologists, and emergency medicine physicians. And the concept was, if a patient or a member chose an in-network hospital, made sure the surgeon was in network, went there, and received care from an out-of-network anesthesiologist, that would be a surprise bill, but the patient did everything they were supposed to. So one of the overriding goals with that legislation was to keep the patient out of any dispute. They should be protected in these circumstances. The model proposed in this legislation is actually very similar. So restrictions on what ambulance companies can bill, and similarly an expectation that carriers pay a commercially reasonable amount. One of the other goals with that earlier legislation, and I will say that legislation followed a study committee that was chaired by Neil Kirk. And in my experience of the department, which is now close to 15 years, I've never seen a study committee work so hard at hearing from all the different interested parties and trying to come up with a solution that really balanced interest as best as possible. I don't think the legislation would have passed without that time investment in hearing everybody and really crafting a solution that met the other goal, which was to avoid any kind of rate setting by the state. And rate setting can happen explicitly. You could say they're going to pay 325% of Medicare, like it sounds like Chicago has done, or it could happen because there's a default that one party is better off under. So in other words, if there's no agreement met between the parties, it defaults to Medicare plus 325% or something like that. Then each party is going to look at where they stand today, whether or not they're better off under the default, and you're going to end up with a default fee schedule in those circumstances. So one of the goals that Representative Kirk had was, let's put language in there around commercially reasonable. Let's make use of the insurance department's access to the claims data to see what other providers are paid, but let's not tell the carrier or the provider enough that a decision about what's commercially reasonable can be made easily. So in other words, they've got to petition the department. It's a public hearing. They basically have to come in and say, this was my final offer, and the other party wouldn't accept it. So generally a pretty uncomfortable process. And the success of that earlier legislation has been very high. We haven't received any petitions from providers or from carriers, and the number of balance billing complaints the department has received in this context, an in-network hospital provider, is very low these days. So I think it's been a success on a number of fronts. But one of the big differences between ambulance companies and those hospital-based providers is at the time that legislation passed, most of those providers were in network. So you didn't want to create kind of a new dynamic with the legislation that would encourage either party not to contract the way they had in the past. My understanding of today's environment is that many of these ambulance companies are out of network. So the likelihood that they would be petitioning the department to resolve a disagreement would be much higher. So the department may have to play a much more significant role in resolving some of these disputes.
Perfect.
Thank
Okay,
you.
Jeffrey, Representative Greason, you have a question for Tyler?
Actually, sorry, thank you. Actually, my question may be for you, since you have a lot more experience, as you mentioned that this bill has been around for eternity. How is this bill compared to previous versions of the bill? Does this bill plug holes that other bills, objections from other bills? Just, I guess, what makes this bill different from what's happened in the past that we would pass at this time and when it didn't pass in the past?
Yeah, well, I mean, basically, that as Tyler mentioned, there was another study committee dealing with a balance billing issue, and that got a resolution. So they took that language and lifted it and tried to apply it to the ambulance. And as Tyler mentioned, what the one downside, the problem is that most of these ambulance companies are not in the network with the hospitals, with the insurance companies. So because they don't have those contracts, I do have Chris Stawas here, he will help you understand the ambulance company's point of view.
And if I may follow up, sir, with you, is there a reason why these ambulances are no longer in network? Or
No, they never were. That's the thing. They
never were. Okay.
Never were. So, okay, put your hand down. That'd be great. So now I'll call on Chris Stawas to offer up his opposition to this bill.
Good afternoon. Can you hear me?
Yep.
Okay. I'm just trying to get my video going here. Sorry. There I am. Well, thank you for the opportunity to speak to you today about House Bill 343. My name is Chris Stawas. I'm a lifelong New Hampshire resident and reside in the town of Hollis with my wife and family. I've been a nationally registered paramedic for the last 35 years and spent my entire adult career in the New Hampshire emergency medical services industry. I'm currently employed by American Medical Response, AMR, which is the nation's largest ground and air medical transportation provider. And I am currently the regional director for AMR in New Hampshire and Maine, as well as their Northeast Regional Director of Government Affairs. AMR is the largest provider of 911 emergency medical services in our state. We are the exclusive 911 provider for the cities
Sorry to
of
interrupt.
Nashville.
The clerk is having trouble hearing.
Yeah. So Chris, your audio is really.
Okay.
Oh, that was better. What did you just do? You
touched my head. Is that better?
Yeah. Okay. It's much better now. Thank you.
Okay. All right. If it goes again, just feel free to let me know.
Well, I see you have one of those here. Yeah. All right, I get it. Go ahead.
AMR is the largest 911 provider in the state of New Hampshire and the ambulance provider for the
Don't bob your head.
I'm gonna switch off this thing. Hold on one second here. Let me.
That might be a better idea.
Let me go to my other method. I apologize for that.
No, can't hear you at all.
Chairman Hunt?
Yes.
The question is, why are they not in service, or what, in-house?
He's going to give us his testimony. We'll get his testimony.
Okay.
Yeah. So.
I just want to make sure what the question he has to
This
answer
is,
is.
he's actually testifying. He's not being posed a question at this point.
Okay.
He's testifying why he's in opposition to this bill.
Okay, I think I'm back.
There you go. That works.
Okay, thank you. Sorry about that, folks. We employ over 200 licensed New Hampshire EMS providers operating from multiple locations throughout the Granite State and transport over 40,000 patients annually. We share the legislative goal of providing our customers with the necessary information to make informed decisions about their healthcare choices. We believe that New Hampshire House Bill 343 is no longer required or in the public interest due to the recent passage of the Federal Surprise Medical Billing Act. All EMS providers have a legal duty to respond to emergency service requests, regardless of a patient's ability to pay. That duty applies to municipal providers like fire departments, commercial providers like us, as well as volunteer and hospital-based EMS providers. New Hampshire EMS providers generally receive payment only when a patient is transported to a hospital. We are not reimbursed for our 24/7 readiness, our response, or even for the care provided to patients at a scene, unless we also transport that patient to a hospital. Nearly 1/3 of emergency ambulance service responses do not result in a patient transport, meaning EMS currently has no ability to pay for those services, but still bears the cost to provide the service 24/7. Interestingly enough, there's actually a piece of legislation in the federal government right now as we speak, which I believe was just introduced yesterday, which would be a temporary gap to that inability to receive service payment for treatment without transport. I believe it was a Senate bill. It was just introduced literally yesterday. The passage of this bill here in New Hampshire as written would essentially force all New Hampshire EMS providers to immediately become in network with all commercial insurance carriers without what we believe any factual justification of what a commercially reasonable value for the services they individually provide is. This would have an immediate and likely devastating impact on numerous municipal budgets across the state, as the badly needed revenue that so many New Hampshire cities and towns depend upon to fund their local EMS systems would suddenly drop. The Centers for Medicare and Medicaid Services, CMS, recently instituted a national mandatory cost study for all ground EMS providers beginning this year, with 20% of all ambulance service providers enrolled annually in the study for each year, the next 5 years. We would suggest that in the absence of meaningful cost data, that it is impossible to determine what a commercially reasonable value for service truly is, given the complex nature of New Hampshire's EMS provider demographics. The cost of 24/7 readiness for an ambulance provider in Berlin, for instance, varies significantly what the cost of readiness would be for an ambulance service in Concord or Portsmouth or Keene. While House Bill 343 makes excellent attempts to find solutions, and I think we all agree that patients should be held harmless whenever possible. The United States Congress recently passed and the President signed Federal Surprise Medical Billing Act that we believe potentially usurps New Hampshire House Bill 343. The new federal SMB law requires, among other things, the creation of a national ground EMS advisory group. That group is charged with determining the safest and fairest possible path for equitable payments to ground ambulance services nationwide. The advisory committee is required to report solutions back to Congress within the next 6 months. We believe that it would be better for patients if the state of New Hampshire did not place duplicative or burdensome regulations on its EMS providers. These additional state compliance costs will inevitably have to be passed on to citizens of New Hampshire and may, in the end, conflict with the newly passed federal SMB law. Even more pressing is yet another national emergency stretching EMS to its limits, especially in the state of New Hampshire, which continues to struggle with an ongoing opioid epidemic, as well as a worldwide pandemic. Ambulance services are a critical part of the front line of defense for the COVID-19 pandemic. As a profession, our expenses have climbed significantly due to increased PPE requirements, paying employees through required quarantine time, as well as their own illness times. Our revenues have dropped dramatically due to lower call transport volume as people restrict their movements and delay seeking care. Adding additional state legislative requirements now potentially puts the continued viability of many EMS providers throughout the state at risk during a time when we can least afford to do so. So we respectfully ask that in the public interest, you find this bill inexpedient to legislate and allow the new federal SMB law to address the issue. I thank you for your time, and I'm more than happy to answer any questions that any members of the committee may have.
Great, because we do have a couple. Representative Abramson, you're first.
Thank you, Mr. Chair, and thank you for taking my question. Do you have services that go across state lines transporting? We have a lot of people. I live in Seabrook, and a lot of people get transported down to Anna Jake's in Massachusetts.
That service area, I believe in those cases would be the Seabrook Fire Department that would handle those.
But I mean, do your paramedics transport people across state lines for transports?
Oh, yes, they do.
And follow up?
Further question, may inquire.
Would this bill, do you think have an impact in cases like that? Would that create additional problems for them?
It's difficult to say. I think it would add an additional layer of something that each individual ambulance service provider would have to be able to examine. In our case, for instance, at AMR, we're in network with a number of different insurance carriers, Anthem being obviously the largest. So from that standpoint, it wouldn't impact us, but I know that many of the 911 providers in the state are not in network with anybody. Simply due to the fact that the amount that the insurance carriers are willing to pay nowhere near meets the cost that the 911 providers incur. And to be forced into those situations like that, literally overnight, as I said, would have an incredible effect on a lot of fire department budgets and municipal budgets across the state.
All right, thank you.
Representative Burrows.
Yes, thank you for taking my question. I guess, Chris, what confuses me, maybe you can help me, is that there are not a lot of businesses that I know of that don't get paid for so much of their services. You said you don't get paid unless you transport somebody. So have EMTs either in state or across the country, have they looked at the business model, and are there any ways that you can get compensated either by, again, this is all new to me, so through the towns or other means, because it just seems like an unworkable system.
Yeah, well, it's not unlike an emergency room, for instance. Many of the folks that go to emergency rooms are either underinsured, not insured, and most of us that have the luxury of being able to be on this call today probably have pretty good commercial insurance, I'm guessing, or we have a federal governmental product that, in essence, in our system of healthcare in the United States today, pays for those people who cannot afford for that care. The ambulance service world is no different. In fact, well, I shouldn't say that. It is different because we don't have the luxury of obtaining a insurance card while you're on the side of the road or having your heart attack in your home. We just provide the service and take you and look for the information later on. So we're at somewhat of a disadvantage that many other medical providers are not at. Yet we still have to provide that level of care.
Follow up?
Further question?
Yes, thank you. Well, with and a disclosure, my husband was an emergency medical physician for 30 years. In the hospital with emergency departments, though, they get bailed out by the hospital by higher revenue generating services like, orthopedics and whatnot. So do these EMT groups ever align with hospitals so there could be a similar scenario where they could finance the parts that aren't paid?
I think in years past, and in my history of work, I previously worked for a company called Rockingham Ambulance, which was part of St. Joseph's Healthcare in Nashua for many, many years. St. Joseph divested from Rockingham because of all of the other costs that they were burdened with as a healthcare organization. They were no longer able to support the ambulance company and literally walked away from it.
Thank you. Thank you for answering that.
Right. Well, but I think the answer to your question is that they do cost shift, and they get to be, when they do actually carry a patient, that they're going to be billed in that bill, whatever that bill is going to be higher because of their underlying costs that they have. They got to get their money somehow. So it's just, that's where the cost shifting is. All right. Representative Van Houten.
Thank you, Mr. Chair, and thank you, Chris, for being here to testify. I note that just about every reference to the word ambulance is preceded by the word ground. Is there a difference both in how it is done locally and in the congressional bill to which you alluded?
I referenced the ground because the other side of that is the air component, and air is federally mandated because of the licensures that are involved. So states cannot have any regulations that they can impose on the air ambulance industry. That all has to come through Congress. So we specifically reference that it's ground ambulance and not air.
Yep.
So the congressional bill that you referenced would cover both ground and air ambulance service, am I correct?
It does. There's actually a piece in the bill that specifically talks to the air side of things, and then one that specifically talks to the ground side, which is the congressional committee that's being put together.
Thank you. Good to see you.
Right. So you're saying they haven't really solved the ground problem. They just set up a study committee to solve the ground problem?
They have, because the difficulty, quite frankly, as I mentioned earlier, is we don't know what the actual cost of readiness and what a fair compensation cost is. And CMS has been tasked with determining what that is. And until they complete that cost study, you're really taking a dart and throwing it at a board. And as I mentioned, there's an ambulance service in our northern most community called the 45th Parallel. What their costs are up there are certainly not what our costs are in Nashua. There's a larger territory to cover. There's a tremendous amount of difference in the demographics, and without a meaningful cost study of what a fair and equitable payment rate would be, as I said, it's a crapshoot. And it's, speaking from what I do, I don't want to take a crapshoot with my budget. It's too important to the communities that we serve and the level of services that we provide. And I don't think many other ambulance providers want to do that either. Now, each community, by the way, can also instill its own cost containment controls. For instance, in Nashua and Manchester, written into our contracts with those communities are caps on the amount of out-of-pocket billing that we can bill our customers. We're only allowed to out-of-pocket bill Medicare plus 25% to anybody that we pick up under those contractual agreements in those communities. And that was those communities' attempt to provide price protection to their constituents. Now, their volume allows them to be able to do that. That certainly wouldn't be the same situation in some of the smaller communities, but in those, it works for them, and they came up with a local solution.
So then, if there's a cap, do you back bill the city? Does the city pay any money?
No, the city. No, in fact, in those two communities, we pay the city money for the services they provide to us in dispatching fees. So we actually pay the cities of Nashua and Manchester several $100,000s a year to have them dispatch our ambulances for us.
Well, this is a complicated one. Okay.
It is, yeah.
Right. So Connie, are you all set then? Yeah, your hand, take your hand out. Okay. Rich, Representative Abel, did you have another question?
Yes, thank you. In the cities where, or the areas where your company operates, do certain ambulance companies have an exclusive arrangement? In other words, does the city license them or the town, or is there competition? So they could call you, they could call someone else.
Most communities where we operate, we're under an agreement with those communities, and the agreement specifies a number of different things, from the types of personnel, their training levels, their response time requirements, what our pricing structure is. For instance, we're required to be nationally accredited in both those communities. So there's a whole list of things that each community would require of the ambulance provider before they would sign an agreement with them. I don't know of very many communities where it's, you call and you can choose from a list of folks. There's standards that are out there that most communities abide by.
Great. Seeing nobody else, so thank you very much for your testimony.
Thank you for the opportunity.
Yeah. So last but not least, Natch Grays from the Municipal Association, and
Good afternoon, Mr.
Order the
Chair.
bill.
Good afternoon, Mr. Chair and members of the committee. So I am an attorney with New Hampshire Municipal Association. I just want to comment on the bill because there are some things that we think are good and some things we are concerned about that our members have reached out to us on. So beginning with the things that are good, our communities have pretty much universally said, and I think that those of you who've been on this committee and heard similar bills through the year have already heard them say that providing payments directly to the ambulance provider rather than to the person transported, and then expecting that person who's transported to then pass that money on to the provider is a good change because there are many instances where persons are reimbursed by the insurance provider and then they do not actually pay the ambulance service. Obviously, they're having a medical issue, so a lot of those costs end up going to other medical bills. But in terms of our concerns, the concerns really center around the commercially reasonable language and how exactly that's going to work out. Our communities obviously don't own hospitals. They don't operate emergency rooms, so they're not familiar with that experience. And the concern is obviously that if, a community runs a ambulance service and then has disputes with insurance providers, that they're constantly running to the insurance commissioner and asking for resolutions for these fees, and they're really in this kind of middle place where they're trying to figure where they're trying to mediate what happens and what the costs are going to be that are going to be associated with that. So those are some of the concerns that we've heard, and I just want to share that with the committee. And I'm happy to take any questions.
Yeah, great thank you for pointing out section 7 and 8. I was so busy looking at the other ambulance issue, I forgot all about that. Yet another ambulance issue that we have, which is that if someone's property and casualty auto insurance, that if they're using the MedPay, the money gets paid directly to the patient, to the car, the policy owner, and not to the provider, which we heard. I guess one example I heard was that some people, they actually had a $15,000 MedPay, and they took the check and went out and bought a boat trailer and, instead of paying the medical providers their due bill and due services. So, any other questions from the committee for Natch? Seeing none, well, thank you very much.
Thank you very much.
And we do have some hands up all of a sudden. We got some other hands up. Oh God, Don. All right. Don Funstein wants to weigh in. And hey, Don, who are we representing today, this afternoon?
Let's see. I'm here again for AHIP. We are pleased to support Representative Weston's bill as it relates to the prohibition on balance billing. Unlike the last speaker, though, we believe Mr. Brennan's explanation is persuasive, and that is we support parties being commercially reasonable as it relates to payment and their other conduct. So we support that provision and the related mechanism in the event of a dispute as well. The only issue we have really with the bill is Section 7. And if that's one of the provisions that Representative Weston referred to earlier as something that she was interested in working on, we certainly would be party to that effort. The reason we are concerned with it is the provision which is being requested that you delete is one actually similar to the commercial reasonableness standard, tends to encourage reasonable behavior as opposed to less than that. And the reason for that, quite frankly, is those of you that have ever dealt with a two-party check know that if people want to cash the check, they pretty much have to come to a mutual understanding in order to do that. That's what's in the current law. We think that makes sense, and for that reason, we are pleased to support Representative Weston's bill with the exception of Section 7. And I still have the vote, Mr. Chairman.
Okay, good to hear. Any questions for Attorney Funstein? Seeing none, we thank you. All right, next is I have Justin Romanello. So, Justin, where do you fall on this issue?
So my name is Justin Romanello. I appreciate your time. I'm the chief of the Bureau of EMS for the state of New Hampshire. And I just kind of wanted to bring some clarifying points as to what New Hampshire EMS system looks like as far as services, if I could. So in the state, we have 300 licensed EMS units, and about half of those are transport and services where this bill would apply to. So they're the one, they have an ambulance and they transport patients to the scene and to the hospital or inter-facility, so between medical facility and medical facility. Of those 167-ish departments, 2/3 are municipal-based services. So they are majority being fire services, but they are municipally based services, with about 45-ish are either hospital-based or, like Chris said, Christewaz, they're a private ambulance service. And again, they're providing service 911 services as well as inter-facility transport. So I just wanted to paint that picture. I know there was some conversations as far as talking about ground ambulances and talking about commercial ambulances, but it is a bit of a larger picture with that. There are municipal-based services. There is only one service that I am aware of that does not bill their residents in the state. It is a municipal service, and they don't bill for any transports whatsoever. But the majority of those departments, that 167 transport and service departments, are in fact going to bill for their services. And to a point that Chris made, as far as not billing for anything other than transports, it does certainly raise the issue that over half of our services that are licensed in the state are providing life saving functions that never bill for that matter. But certainly can answer any questions. I just wanted to kind of paint the landscape of what units are out there in the state.
Are you for or against this bill?
I am neutral.
Okay, great. Do we have any questions from the committee members? Seeing none. Thank you very much.
Thank you.
All right, next we have Chuck Heeman. And you have to unmute yourself, Chuck.
Hello, can you hear me?
There we go. Great. Yes, we can hear
Put it
you.
on that side so it could be easily found.
Well, thank you, ladies and gentlemen, and thank you for the opportunity for me to speak in opposition to House Bill 343. I do agree in lockstep with Chris Stewart. I've known Chris for many years. He's a well-known, very well-respected EMS administrator in the state of New Hampshire. And again, I agree with him completely. So what I wanted to mention to you and make you aware of is the EMS director for the Derry Fire Department. I have been a paramedic for 36 years, and I've devoted my entire life to public service. And as EMS director, I'm responsible for the billing aspect of our operation. So I'm often asked by residents, and why do they get a bill for ambulance transport when they pay taxes? Why doesn't the taxes cover that bill? And my response is typically, in Derry, only 5% of our residents actually use our service. So 95% do not. 95% of people, which is a good thing, do not have a medical emergency that requires a call to 911 in our response. So we look at it, or I kind of look at it more as a user fee to pay for that service. Whether we go to the town tax base and ask for 100% to cover our operations, or we bill for our EMS service as kind of a user fee because only 5% of the people use it. So when I look at our payer mix, and I wanted to kind of explain that to you and see, just so you have an understanding of what we're up against here in EMS. Our current payer mix in Derry, and these are all the payers, 50% of our residents have Medicare. Well, when you have Medicare, we receive 80% of the fee schedule. The patient's responsible for 20%. So I agree with that completely. And I think those that have Medicare, I have no issue with collecting the 80%. And if they have secondary insurance, I will bill their secondary insurance. But as Chris alluded to, CMS is doing the mandatory national cost study, and they've determined that the cost of providing the service is well below what CMS is reimbursing. And we hope to see that change within the next 4 to 5 years. Our next payer group are those with Medicaid. And if you don't know anything about New Hampshire Medicaid, we get a small stipend from Medicaid for an EMS transport that doesn't even cost the cover of our response, never mind the transport. So people with Medicaid have zero financial responsibility. And then about 22% of our residents have commercial insurance. Very few that I'm aware of entertain participation agreements with insurance companies. Anthem is pretty strong in this part of the state. When I came on to Derry 15 years ago, Derry had a participation agreement with Anthem. And when I looked at their rates, they were so low, they were actually below Medicare rates, which is illegal. I couldn't accept those. So myself with town administrators and fire chiefs went to Anthem in an attempt to negotiate their rates. They refused to negotiate. And they essentially said, good luck collecting from our patients because we're not going to pay you if you don't sign an agreement. And then we have about 14% of patients who don't have insurance. As a result of the pandemic, a lot of people have lost their health insurance. So we've seen an increase in patients with no health insurance. And unfortunately, if we were forced into a participation agreement, the patient that would be left with the largest bill would be the patients with no insurance, and that makes no sense. So I agree with Chris Stewart, and I'm in opposition to this bill. I would like to look at the Center for Medicaid Services as they do their national cost study, and I think we should use those numbers. And I am fully aware of the surprise billing legislation, and we should probably weigh into that here as well. So the town of Derry is opposed to House Bill 343. Thank you very much, folks.
Thank you very much. Any questions? Okay. Chair will call on Jeffrey Spencer, and I will promote you, Jeffrey.
Be helpful. Hi, my name is Jeff Spencer, and I run a small company called Medical Business Services. And I'll explain a little bit why I'm here and why I've been involved with this. Some folks probably remember hearing from me last year. I will say that I am in Vermont, not New Hampshire, although I spent, I'm not a carpetbagger. I've been in EMS since 1978 as a provider. To this day, was nationally registered for 30 years. So I've been out there in the field in Vermont and New Hampshire. And then I became, way back in the dark ages, Assistant Attorney General in New Hampshire. So I was involved with drafting legislation. This is back in the, I always say in the Pam Smart era, for those that remember it. So I was an Assistant Attorney General in New Hampshire, and then I was appointed Chief of Fire Standards and Training in New Hampshire also when we built the Fire Academy. Way back when. So my background is as a responder, but also I am trained as a lawyer, although very much a lot of what I do is not involved with the law. I'm not here as a lawyer at all, but say as a matter of background. About 9 years ago, in Vermont and New Hampshire, working with my EMS folks, I saw a need for a billing company. I created our billing company. It's more than a business, though. I'll tell you that. The reason I say that is I'm in the thick of this. All the stuff you're talking about, I deal with every day. We've billed 600,000 calls since we started. I do this stuff every day. I see what's going on in the reimbursement world. That's all I do. So all these things you're talking about, that's my lifeblood. And as a professional and as a person committed to EMS, it's my legacy now. I'm not out there saving lives like I was when I was 25. I'm not the Chief for Fire Standards Training. All I can do right now is help the EMS community and the taxpayers they serve on the reimbursement realm, and that's what we do. And a couple of things. So this is all these things I deal with all the time, and I'm committed to helping you all. And the positives are, I do think this problem can be solved. I do think it can be solved. I think this bill starts, and I know this has gone on a long way, but I think it can be done. And I do believe if everybody knew the realities of EMS, which we've heard from Chris Stewart, we just heard from Mr. Hemian, if everybody understood the realities, I think the solution would become actually relatively clear. I think 90% of the battle is sort of getting the realities of it. There's some undeniable truths amongst, and my customers are the either nonprofit corporations, and there are a couple of them, nonprofits out there, Tri-Town Ambulance down in Pembroke being one, and the municipal services, all of which are taxpayer funded. Bottom line, we're talking about the taxpayers here in the end. This is all about the taxpayers for at least my segment of that pie that Justin was talking about. And I can tell you, I know everybody's rates. I know all the rates. I know the rates nationwide. I've done the comparison. Every one of our customers loses money on every call. And that's why they have to go to the taxpayers for subsidies. Up in Plymouth, the representative from up there that I've chatted with, every one of these services loses money today with their reimbursement. And essentially any of those losses get transferred to the taxpayers. It's an undeniable truth that the rates that are charged today do not cover cost. They're not too high. I would, and I can support that with data. They are not too, so if there's some belief that somehow ambulance services, at least in Vermont and New Hampshire, I can't speak for Massachusetts and everywhere else, are just absolutely gouging people, it's just not the case. It's just not the reality. Our rates are probably, if anything, too low. And as what Mr. Hemian said, you know, he is completely right. This is, and there was a talk about cost shifts. There's no cost shifting in EMS. There just isn't. Of all of our customers, just like what you, Mr. Hemian, say, probably 50 to 60% are Medicare patients. Those are the people that call the ambulance, retirement age people. Fee schedule, and the fee schedule doesn't meet cost. 10 to 20% is Medicaid, and Medicaid, you know, the Medicaid reimbursement rate for a BLS emergency is $145 in the state of New Hampshire. It's $2.68 per mile, and a BLS base rate is $145.50. Like I heard, I think Mr. Hemian called, that doesn't even cover the cost to get the ambulance to the patient. And that right there, that's 50 to 60%. So there is no cost shifting available like in a hospital where they can get it from their MRIs. You know, these municipalities, they run an ambulance and that's it. I can say that the truth of the matter is a lot of insurers out there are using this model right now. They're repricing bills unilaterally. And, you know, the bill will come in for $800 and they'll say, you know, we think it should be $600. And they'll pay $600 and the patient ends up eating that. And the reality is that it's going to be that of the taxpayer. There's no cost shifting. We talked about the 45th parallel. Someone mentioned it. Great example. One of my longtime friends and customers. I think you may remember hearing from Nate. He testified before very eloquently. Their rates are astronomically high. If anybody would look at it, and the insurance companies look at it and say, wow, that's way too much. But they're providing paramedic level service to, and I remember his testimony, to an area the size of Rhode Island. Their rates are really high, and still he has to go back and ask for an incredible amount of money. And I remember what he said, from 4 of the poorest towns in the state of New Hampshire. The reality is coming up with sort of this, let's look at what everybody else is paying, unfortunately, as a methodology isn't going to work. And the reason why, I know people might think, wait, why come they're not in the network? It's exactly, there's no motivation to go to a place like the 45th parallel. The amount of discounts that were required to join the network made that situation even worse. So most of these municipalities aren't in network. They simply can't afford to be because of the rates allowed. But I guess I'd say there is a solution. And I know I am absolutely more than happy to, and I don't have a real stake in this. I am just here because I think it's the right thing to do, and I'm concerned about the future of EMS. From a fiscal standpoint, more than happy to work with Mr. Brennan and also the gentleman from the Municipal Association, because I think I can see some sensitivity in this bill that there's a solution that people are shooting for. I think it can be done. I do believe that the methodology, just when you step back and look at it, if we want to protect the taxpayers and we want to protect the patient, we have to somehow find a way to make sure the payment rate covers costs. The reason for the balanced billing problem when it comes to ambulance services, and I'm going to only speak for Vermont and New Hampshire, is because the rates are too low. And the reimbursement rate is too low, so the taxpayers have to keep subsidizing that operation. And the answer to it is to get the rates to be consistent with costs. And that's the solution to that one. So I am opposed to the bill in its form, although I think there's stuff that can be done. And I know probably people's eyes are glazing over because you've heard this issue for so many years. I will say to you as a person that's in the thick of this, and I do believe I sort of know my way around legislation, this can be solved. I'm just not quite sure we're there yet. So thank you for letting me speak.
Thank you. I don't see any questions from the members, so thank you very much.
Sure.
I now have 3 names, so I would say all these people didn't sign up ahead of time, but but I'm certainly not going to send him away. So the next up is Jerry Stringham. And there you go.
Thank you. I'm Jerry Stringham. I'm a former state rep from Lincoln and Woodstock, New Hampshire. It's nice to see many of you again. And Representative Ham, who currently serves our area on the committee. Nice to see you as well. I was asked to express concerns about HB 343 from Linwood Ambulance to this committee. Ambulance services in rural New Hampshire are a critical part of the health structure and emergency response system for our residents, and also the out-of-state visitors who enjoy the White Mountains up here and often get involved with rescues. What I have to say isn't much different from what you heard. Certainly we agree that the bill's goals of removing balanced billing is laudable, and there's been considerable thought that's gone into its planning. But rural ambulance services like Linwood Ambulance have concerns. They feel they have no leverage over insurers in terms of setting fair rates. They're generally not under contract. The rates will not take into account the very high readiness costs in rural areas, all things you've heard. And they are too small a player for the insurance commissioner to be of much help. The simple ask here is that the concerns of critical services like Linwood, which is, really almost a central element of our healthcare system in here, be taken into account before finalizing the bill. And I know a lot of good work has been done today. I know that David Tauber, the chief of Linwood Ambulance, was planning on listening in on this hearing and probably be better to answer any questions that you have. But thank you for this opportunity to speak and for taking our concerns into account.
Fair enough. Thank you very much. All right, to left, Justin Van Eaton. He's in limbo land right at the moment. Justin, are you there? I saw a square pop up for him, but nothing happened.
I see a square and it doesn't seem to be muted.
Yeah, he's there, but not there. There he goes. I think he had to reboot. And now you got to take your mute off. There you go.
There we go. Sorry about that. It was just, I got the spinning screen of death there for a moment. Thank you all for your time. Thank you, Mr. Chairman. I will tell you that to the best of my recollection, it's been at least a decade because my daughter was born in one of the first hearings I was involved in on this, and she just turned 10. So at least for my involvement, I think you were chairing it back then. My name is Justin Van Etten. I live in Holderness, New Hampshire. I'm the head of Stewart's Ambulance, which is one of the largest ambulance services in the state of New Hampshire. We are also headquartered here in New Hampshire, and we have been for 40 years. I'm just going to try and touch on a couple of issues that people haven't mentioned. First and foremost, I will tell you, we as a company, our corporate policy, it's been this way for 3 or 4 years. We do not balance bill for anything other than copays and deductibles. We do this because I live in the communities we serve, and it seems like every time we sent out a balance bill, they were a friend of my mother-in-law's, and I would hear about it, and I got lots of angry people in my community. So we went to our towns. In order to not balance bill, we had to almost double what we charge up front. So we went to all of our towns. We represent about 9 towns, and said, this is what we're going to do. And so we haven't balanced billed, and that has worked out really well for us. We would comply. I was talking to Representative Weston and Representative Marsh about this. We would comply with this bill, which is a good thing. But I have real concerns about the power that this would hand to the insurance companies. Because one of the problems, as I understand it, and Chairman, you probably understand this better than I do, but insurance companies are required to have a certain number of primary care physicians or eye doctors or orthopedic surgeons in every region. They don't have to. Yeah, they don't have to have that for ambulance. So they have absolutely no motivation to contract with us. That's why nobody's in network with them. And, you know, I know from my discussions, because I also serve on the board of Massachusetts' largest ambulance company, I would get paid the exact same rate in downtown Boston that I would in the northernmost reaches of New Hampshire. And it's that way because, again, there are no requirements of network adequacy on insurance plans here in the state. The next thing, and part of that challenge, Chris mentioned this, when it comes to cost studies, I work in urban areas in New Hampshire and I work in very, very rural areas in New Hampshire. In my very rural areas, I did the math yesterday, it cost me about $1,100 every time I transport a patient. In urban areas, it costs me between $300 and $400 every time I transport a patient. And so there are huge swings in my cost. And every time I have seen an insurance, a study out of the insurance commissioner's office, they've been great studies, but they've never focused on the cost of providing this service. And you've heard for 45th parallel, the costs are stratospheric. So I say all of this because I can certainly understand the problem and challenge of balance billing. Like I told you, I live here, so I've gotten yelled at for many a balance bill that we've sent out. It's why we no longer do it. But I think there has to be some fairness, because otherwise what the insurance companies, I suspect, will do is next year they'll pay me 2.5% less. And am I really going to appeal it? And is the insurance commissioner going to support me? And, you know, it's a hard battle. And then the year after that, it'll be 2.1% less. And then the year after that, it'll be 1.6% less. And it'll quickly make EMS in New Hampshire simply not work. It barely works today. So if you're going to move forward with something like this, two suggestions that I would ask you to consider is, one, it shouldn't be solely the insurance commissioner's prerogative. There should also be a representative from the Commissioner of Safety, because Mr. Romanello understands that there's huge differences in the cost of readiness for rural communities versus urban communities. And I don't think that is understood necessarily by the insurance department. They're wonderful people. It's just not what they do. And secondly, I think you would have to put a provision in a bill like this that requires insurance companies to have some level of adequacy throughout the state, so that they do have to have some sort of a contract with people in the Lakes region and you know, in Coos County, so that right now, when we negotiate with these insurance companies, it's all me sitting there going, you know, please, will you give me? And they don't care. If you required them to have a network, they're going to have to come to the table and they're going to be motivated to work with us too. So that's it. It's a snowy day. I'll cut my comments off at that for all of you, but thank you all for your time. I greatly appreciate it.
Yeah, but before I let you go, you really are balance billing. You're balance billing the towns, not.
Yeah, that is absolutely true. So the town, it's a good point. The towns that cost me over $1,000 a call, like the Lakes region towns where I live, they pay me annual subsidies of about $600,000 a year. So the taxpayers are balance billing it. In communities like, say, Somersworth, which is a city with a high degree of call volume, they have the volume that, like Manchester and Nashua, we don't charge Somersworth a subsidy. They get that service for free. So you're absolutely right, Chairman. There is balance billing, but it's the taxpayers that get balance billed.
Okay. Thank you very much for your testimony. See no questions. Okay, last person up, David Tauber. And I see that you got yourself all ready and raring to go.
Thank you, Mr. Chairman. My name is David Tauber. I am the chief of Linwood Ambulance in Lincoln and Woodstock. I thank the former representative for speaking on our behalf earlier. I'm a 30-year resident of Conway and used to work with Dr. Burrows, providing EMS in the Conway area for many, many years. There is a huge disparity between the cost of service between the various services in the state. And I'm very concerned, as the last speaker said, about simply the insurance companies having all the power to set the rates. We are a volunteer nonprofit service. So we get a small subsidy from the two towns. We do not balance bill state residents, but we're also a huge tourist town. And when we pick up 130, 40 people from the two ski areas in our jurisdiction every year, and they happen to live out of state, we often collect nothing because the insurance companies pay the policy owner, and the policy owner pockets it. And we have no way to go after them out of state. So there's a huge issue there too. When you talk about how we cost shifting, it's cost shifted onto our volunteers. Our volunteers who stand by to respond to these calls. And these huge readiness costs of having standby ambulances. We have a 26, 27 mile one-way run to each of our hospitals. That makes for a 2-hour run for our volunteers round trip. A long dead leg where the ambulance is out of service. So we have second and even a third ambulance here in a town that really doesn't justify it for the call volume because there's no nearby mutual aid geographically. And we don't have the call volume to put in an AMR or a service that's actually going to make money by volume. So we have huge concerns with a bill like this.
Great, thank you. Any questions from committee members? Seeing none, we thank you very much for your testimony. Appreciate you coming on. And I have no more hands up, so I guess that's a good sign. And I know you guys are all interested to hear what's happened on the blue list. So there are a lot of names here. And I would say, Joyce, they're all 603. So we don't have to worry about out-of-state people. They're all on there. There's only a handful of other oddball area codes. So that's the one way I get to track to see where they're really calling from, or where they're coming from. But the upshot is there are 38 people in support, 25 opposed, and 4 neutral, and that is what the blue sheet has. Having no more testimony, we will close the public hearing on House Bill 343. And that ends it for the day. Dun, 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 dun. Okay. So any questions or comments, or anybody want to reflect before we say goodbye and do this again tomorrow at 9 o'clock? Yes, Representative Abrahamson.
Yeah, Mr. Chair, are we going to break all of these bills up into their various subcommittees, or are some just going to be, do you think?
Well, as I said before, we really don't have time for subcommittees. We're not, so at this point, unless the bill just needs a little tweaking here or there. I mean, a bill like this, the best we can do is retain it and work on it come September. In terms of, you got to vote either up or down or we're retaining. And so any bill that's going to need amendments or something, I really think we're going to just end up retaining it.
Fair enough.
So Representative Burrows.
Yes, thank you. Just a quick housekeeping question. Just
Yes.
curious on Commerce, do you ever institute time limits for people testifying?
I generally have said, myself, I'm pretty good, never perfect. I'm pretty good at scheduling enough time so that we don't have a problem. I would say there have been times where I would say to people, please don't repeat the testimony that we've already heard. So if you got something new to say, great. But that, and I would say, over my many years of being a chairman, I've usually time it pretty closely. I got it pretty good, but there have been times where I've had to tell people to please be a model of brevity or just submit written testimony, but it hasn't happened.
Thanks for that.
Yeah. Yes, Representative Petusek.
Also, in a lot of cases where we have received testimony by email, when we were in 302, a lot of the people who come in to testify want to read the exact same thing that we've already been emailed. And I know the chairman tries to push them off from doing that also.
Right. Well, I would say that another feature of the card we had was the person says how much time they're going to have, and I would say the sheet that I'm getting, it is there. It's a very small print. So, but fortunately, I have bifocal contact lenses, so I can see. And most people were, say 5 or 2 minutes, or they just say 0 minutes, and I know that that ain't true. But I would say whenever I would see someone who put in a big long, 10, 15, I would tell them to cut it. So, are you all set, Max, or you just haven't taken your hand down, or do you have something else you want to ask me? Okay, perfect. Okay, we'll see you all at 9 o'clock tomorrow morning. Thank you. Bye-bye.